I want to welcome everyone. Thank you so much for being here. I know a few folks are still getting coffee and breakfast, but if we can all gather together and take a seat at your convenience. My name's Alison Barlow, and I direct the Center for American Indian Health here at Johns Hopkins, and it is an incredible honor to have this gathering. We're very humbled by the folks who've come together in this room to really focus on family, the nexus of strength in Native communities. We have so many lessons to learn from Indian country about how family is really the core strength for all of us. And I know we're gonna have an amazing day. To get us started in a good way, I'm so grateful to welcome W.J. Strickland. This conference and this partnership with NAFA and Johns Hopkins Center for American Indian Health really was his idea. So thank you, W.J.
Thank you, Allison. Good morning. Al, as I look at you this morning, I recall when we met at the Gaylord, December 2015. Who would have thought that we'd be here today? That's the Great Spirit working. I'm so honored and blessed this morning that I have this opportunity to work with such outstanding individuals that operate Johns Hopkins and the Native American Children and Family Association. So as we begin this morning, I'd like to ask you to stand, and I'd like to ask you to circle the room and join hands in a circle. So wow, you did a good job. You must have come from Head Start or something. As we begin this time together, I want to have you to first 30 seconds or so, I want you to bow and give thanks to your ancestors who allowed all of us to be here today. Grandfather, Great Spirit, once more, we are here gathered together to lift our voices on behalf of the children and families that you have so blessed us with. All things are blessings to you. We have made this journey on this road, and we had some challenges along the way, but you preserved, and we are here because it was good hearts that worked together to make this day possible. We ask your blessings upon each one here today. We ask you to remember their families that have allowed them to come to be here. We ask that whatever we do here today, that would be for the next 7 generations to carry forward the great opportunity and blessings that you blessed us with. All these things that we say and do, we honor our children, our most precious. In your name we pray, amen. Thank you so much. Be seated.
It's my pleasure to introduce Mr. Albert Cooley from the Native American Fathers and Families Association. We've just gotten to know this organization over the past year and feel incredibly honored to be working in partnership with you. We realize that you're deeply embedded in Native communities, and you're led by an amazing person, and we're just so grateful. So thank you.
I'd like to welcome everybody this morning. As was said, my name is Albert Cooley, but please just call me Al. I am half Hopi and half Navajo from Arizona. That's why they say I'm all crazy. A little bit about myself. I met WJ, like he said, a while back, and we just hit it off. And he was the director, or partner, if I get the right, but he was in charge of all the Head Start for Native Americans, and him and I just hit it off. But anyway, I want to welcome you all, and like was said, all of you here are real leaders in your own community. I want to thank you for your hard work, for the work you've done, and for the vision you've had. In our program, we say this: the heart of our Native American culture is not the language, it is not the food, it is not the customs, it is not the dress. The heart of who we are is family. And what happens to someone when their heart stops beating? They're dead. Once our families are broken and scattered, we are dead as a people. We can pretend and act like we're Native Americans, but we have to focus on keeping our families together and keeping them strong. And so I'm really glad. I want to thank Johns Hopkins for letting us join with them. They're a very outstanding institution, and just like our families are, our families are the heart of who we are. Again, we have a very busy agenda today, and I'm looking forward to some of the speakers here. In fact, all of the speakers. I've never met Dr. Warren, but I've heard so much about. Where is he at? There he is over there. I've heard so many good things about you, but I've never met you, and so I look forward to visiting with you, and I'd like to meet all the rest of you. One thing more about me, if you forget my name, I'll just remember me by this. About a few years ago, one of my granddaughters was sitting on my lap, and she was looking right into my face. And then she asked me a question that I didn't know how to answer. Well, I didn't know how to answer it. But she says, "Grandpa," I says, "What, honey?" She says, "Were you ever cute?" And I says, "Well, sweetheart, I was never as cute as you." She says, I thought so. So I'm the Indian guy that was never cute. One last thing, I had brain surgery about 6 weeks ago, and as my doctors came in to talk to me, there was two physicians, and one of them was a female, and she's the one that actually performed the surgery on my head. I got scars here. My wife gave me some things to cover my scars up, and so she said to me, I says, just joking with her, I said, "So was I scalped?" And she says, "Yes, you were scalped." So I can honestly say I was scalped by a white woman, okay? So that's who I am, the guy that was scalped by a white woman, and the guy was never cute before, okay? Thank you.
It's now my incredible privilege, honor to welcome Dr. Donald Warren to start us off with an opening lecture that will tie together many parts of the day. Oh, sorry. I'm so sorry. So before we have Dr. Warren come up, we actually have to pay incredible gratitude to the Casey Family Programs, who has supported this conference today along with Aetna Foundation. And we came to Casey again in the fall, and it was so quickly that you moved to help us with this conference. So it's my pleasure to welcome Anita Fine Day up to say a few words. Thank you.
I actually would have been just fine. I didn't want to have to follow Al, so I can't match those stories. I haven't been scalped. And so I just briefly want to say thank you for attending. We are just thrilled about this event. It started, I think, last summer when we had an idea. Attended a conference with someone from Johns Hopkins, and we realized we're doing the same work, and but we don't ever talk to each other. And so we thought, wouldn't it be great if we could all come together and talk about the well-being of Native American children? So we're thrilled that this has happened, and we hope that this is the first of many sessions working together. So with that, I'll turn it back over to Alison. Thank you.
Thank you. So grateful. So Dr. Don Warren, I know he is well known to many of you. He's professor and chair of the Department of Public Health at the College of Health Professions at North Dakota State University, and a senior policy advisor to the Great Plains Tribal Chairman's Health Board. He's also someone who has worked in so many different Indian communities throughout his lifetime, and he's someone who I know when he speaks, we all listen very carefully because he has such a gift to tie together complex ideas in a way that is very digestible to all people. So I don't want to stand between him and you, so Dr. Warren, thank you so much for being here.
How Palama Yolo, mitaku yepi. Hello, thank you, and welcome to all my relations here today. Very honored to be a part of these important discussions. Oh, is this one? Okay, thanks. There, that's me. Very good. This is an incredibly important arena when we think about the health of future generations, and it's also very consistent with a lot of our traditional belief systems. And I'm so happy that we are focusing also on fatherhood. And it's been one of my, I wouldn't say a disappointment, but one of the challenges I think that we have in public health is we have this whole arena of maternal and child health. What's missing in that equation, right? The role of fathers. And I think when I look at our traditional ways, certainly in the Lakota way, we didn't have a nuclear family. You know, that was kind of imposed on us, this whole idea of a mother and a father and children. We actually had entire communities raising children. And it was the role of one generation to be the parents for the next generation. So it included aunts and uncles. And we, of course, don't have the data or any way to prove it, but the elders tell us that children used to be better behaved. They used to feel more safe. They used to feel more secure because they had an entire generation of the previous generation of aunts and uncles and parents that were caring for them. So I really like the theme of this, engaging the strength of family to promote lifelong health. And one of the lessons from our traditional ways is that we're not just a nuclear family, right? We're not just mother and father and children. We have to look at our entire communities. And in truth, the health of a community has an impact on the health of the families. And the health of the families has an impact on the health of the individuals. So we can't look at this in terms of just one-on-one patient care, but we also have to expand our focus and recognize that there's more to family than just the nuclear family. Well, I'm originally from Kyle, South Dakota, and I'm sure there's people who have actually been to Kyle, South Dakota. I know there's some Lakotas who are here. The original name of Kyle is Prejutahaka, which means medicine root. And in this area, we have a lot of our traditional healers who are from here. And also, there's an area called Yellow Bear Canyon that has a lot of our traditional herbs that we still use for medicinal purposes. So where I'm from, really in many ways, is medicine root. It's the root of our medicine. And when we say medicine in the traditional way, we don't just mean pills or medications. We're talking about healing energy. And the whole idea that the health of a community can have an impact on the health of our individuals. I'm currently working in Fargo, North Dakota. I'm chair of the Department of Public Health at North Dakota State University. And we have the only Master of Public Health in the nation in which you can specialize in American Indian health. So we actually have an American Indian Public Health specialization. We're relatively new. We've just had 5 cohorts of students. and we matriculated now 107 students in total, and of that number, 27 are American Indian. So we're trying to build the next generation of American Indian public health experts, and certainly this whole arena of community health focused on the family is a vital component of that. This is a picture of Little Wound School in Kyle, named after Chief Little Wound, one of my ancestors. And on the far left is the kindergarten, on the far right is the high school. One of our big challenges that we face, not just in my home community, but many of our home communities, is that less than half the kids who start kindergarten finish high school. Our dropout rates in many of our schools are over 50%. Now, why is that? Is it that our kids just cannot perform academically? Well, absolutely not. The social circumstances in which many of our children are being raised actually precludes them from being successful. And we'll talk more about adverse childhood experiences. But when we have children growing up in challenging conditions, it has an impact on their neurological development, cognitive development, social development, and quite often the outcome is that they drop out of school. And that's not a reflection of their intelligence, it's a reflection of the community dynamics and the social circumstances in which our children are growing up. And we need to return to a traditional perspective that ensures and includes the entire community in the process of making sure that we have healthy children. The other challenge coming out of this is, where's the next generation of leaders going to come from if our children are not finishing high school? Where's the next generation of doctors or nurses or business leaders or educators going to come from if we don't have children finishing school? So one of the reasons I kind of changed my career from medicine to public health is that in medicine, what I found is that I could have an impact one patient at a time. But in truth, the health issues occur long before people get to the doctor or to the hospital. And I started my career as a primary care doctor at the Gila River Indian community in Arizona. And they're well known. They have the highest rate of type 2 diabetes in the world. And what I realized very quickly in my medical career is that the challenge is not a lack of medications. It's not that we don't have enough insulin in the pharmacy. That's not the problem. It's all of the social dynamics that are leading to health disparities. And we're seeing really strong evidence that adverse childhood experiences lead not just to mental health considerations, but also to things like diabetes and cancer and heart disease. Well, right across, or right next to the Little Wound School is the cafe in Kyle. And I've gone here more times than I'd like to admit, actually, for food. But I think what they've learned here is that you can bread and deep fry just about anything and serve it for lunch. So where I'm from, it's a food desert. I'm sure many of you have heard of the concept of a food desert. But the closest supermarket is in Rapid City. So it's a 100-mile drive. So 200-mile round trip to go to a supermarket with fresh fruits and vegetables. The other reason I like this picture, it's an action shot. You can see the res dog chasing the little girl down the street here. Well, right across the street from the cafe is the gas station. And the gas station does double as a grocery store as well. So it's a convenience store. And there's a small section for fruits and vegetables, but we'll put fresh in quotations in terms of the fruits and vegetables available here. Within public health, there's another concept called a poverty tax. And it's not a tax per se where the government is charging a percentage or a fee, but people who live in poverty spend more money on healthy food choices than people who live in more affluent communities. So to purchase fruits and vegetables here, it actually costs more money than if people lived in Baltimore or in Rapid City, for example. So we have all kinds of challenges facing us. The social dynamics, certainly the economic circumstances, and this leads to all kinds of disparities. And when we see challenges within our population in terms of health, that does have an impact, obviously, on our family dynamics as well. So a picture of one of my uncles, and he has an amputation. Why does he have an amputation? Diabetes. Isn't it amazing that everyone knows that now? 40 years ago, if you asked that question, why did somebody have an amputation? They'd probably think it was from a war, right? They must have been a veteran in combat. Now we just know that poorly controlled diabetes leads to things like amputations. And unfortunately, we have very high rates of complications in our communities as well. So not just diabetes, but the complications of the disease. Now what's fascinating is that in my community and many others, there's a program that will build a ramp for people who are in a wheelchair. And it's wonderful, so they can actually have a ramp and get into their home. But wouldn't it make more sense if we invested in healthy food in the first place? So we wait until there's an amputation, then we'll invest in people's needs. But we don't invest in primary prevention in the first place. So again, a lot of challenges related to our social circumstances and how can we address this in a meaningful way? And in Lakota, we didn't have a written language historically. And we would learn about our belief systems and our traditions through oral history and through stories. And there's a traditional story about 3 sisters walking along a river. And as they're walking along the river, they see babies and young children struggling to stay afloat in the water. The first sister jumps in and says, "This is a crisis. It's an emergency. We need to get the babies out of the water right now." The second sister says, "No, we need to teach them how to swim so they can survive while they are in the water." And the third sister just keeps walking upstream. And the other 2 ask her, "Where are you going? Why aren't you helping us?" And she said, "I'm going to find out who's putting these babies in the water, and I'm going to stop them." That's public health. That's primary prevention. And when I think about what we do in our communities, we spend almost all of our resources on crisis management, right? Dealing with emergencies, dealing with complications, waiting until there is a crisis until we intervene. Now, a lot of that has to do with lack of resources, which is a whole separate policy discussion for Indian Health Service and related programs. But if we think about this from a traditional perspective, we also spend the majority of our efforts in many of our communities on crisis management. When we think about dealing with families and children, we're thinking about crisis management rather than preventing the crises from occurring in the first place. So we need a public health lens through which to see family health and community health. And in truth, public health is traditional medicine. And I always like to remind our people that this isn't a new concept for us. This isn't new age medicine, this is old age medicine, recognizing the need for a healthy community to have an impact on the health of our families and individuals. I'm sure everyone's familiar with the IHS areas, 12 areas. And another thing to keep in mind, particularly for those who haven't worked a lot in Indian country, is that there's a lot of diversity within American Indian populations. There's not a single American Indian culture. I always find that fascinating when people say the American Indian culture. That's kind of like saying the European culture. Is there a difference between Sicilians and Scandinavians? Quite a big difference, right? We see at least that much diversity within American Indian and Alaska Native populations. And unfortunately, one of the big challenges that we face where I'm from is that some of the worst disparities are occurring in the northern tier of the United States, the Great Plains area, Billings area, and Bemidji area. We tend to see some of the worst outcomes in terms of life expectancy, average age at death, infant mortality, and all kinds of other considerations. And for my brothers and sisters from Alaska, I apologize. I know Alaska's not off the coast of California, but this is the best map that I have. So this is looking at American Indian population by state. And these are the 7 states that have at least 3% American Indian or Alaska Native population. So Alaska, Montana, the Dakotas, Oklahoma, New Mexico, and Arizona. And was it always this way? Did we always have American Indians just in the western half of the United States? Historically, did Indians not like the East Coast? Well, no. The other thing that we have to keep in mind as we're addressing disparities is that we can't look at this in the silo of our perspective in 2017. We need to understand history. We need to understand why we are in the circumstances that we are in. And these are difficult discussions, but it's very important to understand the social dynamics and the historical dynamics and the historical context for American Indian people. So when I show this slide, I always like to say, let's talk about Indian country. It's all Indian country, right? This is indigenous land for the indigenous people. And of course, this is just the 48 states. We did not draw the lines between US and Mexico or US and Canada. And there are tribes right on the borders as well. So certainly the Tohono O'odham Nation in Arizona has tribal members in Mexico. Turtle Mountain Band of Chippewa Indians has tribal members in Canada. So we'll just look at the 48 states and recognize that the 13 colonies were not good for the northeastern tribes. You know, one of the outcomes of loss of land and loss of territory is that now we have 35 states with federally recognized tribes, meaning that there are 15 states with no federally recognized tribes. And ironically, one of the states without any federally recognized tribes is this one, right, Maryland, home of IHS headquarters, which is the state, one of the states home to no tribes, ironically enough. So maybe we need to declare headquarters a federally recognized tribe, and we'll have another representation. So you may have heard of Amherst, Massachusetts, Amherst College. Lord Jeffrey Amherst was a colonial governor, and he's very famous because he is the one who ordered the distribution of blankets from a smallpox hospital with the purpose of wiping out tribal nations in the Northeast. And they did this very successfully. And unfortunately, this is not in our history books. And it's remarkable to me, I tell this story frequently, and how many people have no idea that this ever occurred. And you can actually Google Amherst and smallpox. I like how the word Google is now a verb, right? We can Google things. But you can actually see the letters written back and forth between Jeffrey Amherst and the colonial army at that time. And their purpose was to wipe out the northeastern tribes, and they did it successfully. So our earliest documented case of bioterrorism is our own colonial government. We don't like to talk about that as Americans, but because it's an unpleasant component of our history, but it's the truth. And the only way we will get to equity is to go through truth, even if it's unpleasant, even if it makes us uncomfortable. That is not the main focus that we should be considering as our comfort. Our main focus should be truth and equity. And that's the only way we will get there, is to recognize the truth. Now, I'm sure you've heard of the Trail of Tears. Many of the southeastern tribes were moved to what is now Oklahoma. And in that process, a lot of the tribal populations were split apart. And as I can imagine, if I was in that time frame and I had the option of being removed to Oklahoma or staying in my home territory, I would want to stay in my home territory. A lot of people did that. So as a result, that's why we have Seminoles in Florida and Seminoles in Oklahoma. That's why we have Cherokees in North Carolina and Cherokees in Oklahoma. That's why we have Choctaws in Mississippi, Choctaws in Oklahoma. Those populations were kind of torn apart. So there are 38 federally recognized tribes in Oklahoma, of which only 4 are from Oklahoma. The rest were relocated. So ironically, there was a date set aside for Oklahoma to be Indian Territory. That's when our tribal populations were able to move into Oklahoma and set up their own communities and reservations. Anyone know what the mascot is for University of Oklahoma? Sooners. Yes, a lot of people don't know what a Sooner is. So there was a date set aside for the tribes to stake their claims in Oklahoma, and the non-Indians who got there sooner took the land. So a Sooner is actually a land thief. So it probably wouldn't engender as much school pride to be the University of Oklahoma land thieves, but that's essentially what a Sooner is. And again, unpleasant. I have a lot of friends who live in Oklahoma. My wife's father's family is from Pawnee, Oklahoma. A lot of Sooners fans. But look at the irony there. You know, we're embracing this change in our culture and embracing the whole idea that our land was taken. When we have loss of land and loss of resources, can that have an impact on poverty? Can it have an impact on resources for the next generation? And clearly it does. So the reason these things are important to understand in terms of health inequities and health disparities is that we have lost so much territory, so much in the way of resources, and resulting intergenerational poverty. Well, the discovery of gold, of course, was not good for the California tribes. Unfortunately, many of the tribes in California were also wiped out. So this is what we're left with. This is the concentration of American Indian population by county in the United States. Look at all of that loss, all of that tremendous loss. We had American Indian people living throughout what is now the United States, everywhere. And there's still evidence. You know, we still find evidence of tribal populations all over the country and archaeological findings. And you know, we look at that as fascinating academic and historical activities, but those are our people. Those are our ancestors who were removed from their homelands. And when we think about what's happened now, we're primarily in the western half of the United States. Again, with only 35 states with federally recognized tribes, that means that 15 states, and therefore 30% of the Senate, has no tribes in their constituencies. Do they care about our issues? If they advocate for American Indians, will it help them get reelected? Well, absolutely not. So we're at a huge political disadvantage as well. And we have to look at this in the way of systems thinking and recognizing that if we need more resources for fatherhood and family programs, and we need more resources for things like home visitation programs and parenting skills, we're going to need Congress to be on our side. And one of our big disadvantages is simply our demographics and the political disadvantage that places us in. But again, we've looked at states where we have a lot of American Indians, certainly Alaska Natives in Alaska, then Montana, the Dakotas, Oklahoma, New Mexico, and Arizona. We have a lot of American Indians still here. But we did see, unfortunately, a lot of loss. At the time of contact, it's fascinating, Columbus never actually set foot in what is now the United States. And the reason that we are American Indians is because he thought he was in India. So actually Columbus was lost, therefore we're Indians. Isn't that remarkable? So that's why there's the West Indies. That's why there's an Indian Health Service, a Bureau of Indian Affairs, is that Columbus thought he was in India, therefore we're now Indians. So fascinating development. But at that time, it's estimated there were probably about 20 million indigenous people in North America and South America, and of that number, probably about 5 million in what is now the United States. By 1900, our numbers were down to 200,000. Isn't that amazing? From 5 million to 200,000. It was almost a complete genocide. This was the American Holocaust. We don't frame it in those terms, but we need to. This was the American Holocaust. This was almost a complete genocide of our people. But if we look at the numbers now, according to the 2010 census, 5.2 million American Indians and Alaska Natives. So our numbers have come back. But this process of loss of population, loss of language, loss of culture, loss of territory, loss of resources, has an impact on the health of our people today. So we have to think about this in terms of historical context and understanding why we are in the circumstances we are, but what can we do about it? So I love the research that's going on now in historical trauma and recognizing the impact of stressful events on entire populations. And a lot of this research originally came out of the Holocaust survivors and how their children and grandchildren were adversely affected, even though they didn't directly live through it. So we're seeing some good research occurring in the area of historical trauma. And a lot of that's based on epigenetics. I'm sure a lot of you are familiar with epigenetics. But we can see that DNA is impacted by highly stressful events in several ways. We can see methylation of DNA, which can have an impact on gene expression. We also see an impact on telomere length. Now, the telomere, where the cell divides, shortens over the lifespan as we get older. People who live in highly stressful circumstances have shortened telomeres. So we're thinking that perhaps these highly stressful events are speeding up the aging process and really having a direct impact on our disparity. So I think epigenetics will provide the scientific foundation to better understand historical trauma. Another issue that's unique to our populations, and it seems like indigenous populations worldwide, even in Australia and in Pacific Islands went through this, and certainly First Nations in Canada with the residential schools. But we had boarding schools here in the US, and the boarding school era was not that long ago. My own mother is a survivor of boarding schools. She's now almost 80 years old. She still won't talk about it. She doesn't want to talk about it. Horrible experiences in the boarding schools. And many of our children were taken away from their families and put into institutions, in many cases, more than 1,000 miles away. This is a picture of the graveyard right next to Carlisle Indian School. And Carlisle is one of the more famous boarding schools. It's in Carlisle, Pennsylvania. That's where Jim Thorpe was a student, one of the famous athletes in the first half of the 20th century. But when we look at the boarding schools, almost all of them have a huge cemetery right next to the school. Why is it that so many Indian children were dying? We do know that there were outbreaks of things like tuberculosis, but that doesn't answer all of the excess death that we see in boarding schools. And each one of those headstones represents an American Indian child between age 6 and 12. So why is it so many of our kids were dying? And what happens to the survivors? Does it have an impact on you if you're in elementary school and so many of your friends and playmates are dying at an unnatural rate? That has a huge impact on that entire generation. So the generation of boarding school survivors, I think, has a lot of unresolved trauma. And that unresolved trauma is having an impact on the health of our families and the health of our communities, even to this day. Another thing that we have to also consider as we look at this timeline from history to chronic disease disparities in current times, we also have had gestational stressors. We unfortunately have a lot of unplanned pregnancies, and quite often we have children who go through very challenging childhoods and are self-medicating with alcohol and other substances, and then quite often we see unplanned pregnancies, unfortunately. And quite often, very stressful environments while the mother is pregnant. That has a huge impact on the baby subsequently. Now, we're all familiar with WIC, right? Women, Infants, and Children. And I'm so glad that we have the fatherhood and family program here too, because women, infants, and children, what's missing in that equation? Is a single father eligible? Is it wise to be creating more silos? We have to think about these things, don't we? And when I was working as a primary care doctor, it's now been over 20 years ago at Gila River, the WIC program really was a baby formula distribution center. You know, they didn't promote breastfeeding the way that they could have historically. They're doing a much better job now. They've made some significant improvements. But when I was, again, working as a primary care doctor, people went to WIC just to pick up their formula. And it's interesting, we see higher rates of things like diabetes among people who were formula fed as compared to those who were breastfed. And breastfeeding obviously is natural, and how our many generations have survived long before there was formula. And it's interesting, the word formula. I mean, it's called formula for a reason, right? There's chemicals in it, basically. It's like, how about a nice glass of formula? That doesn't sound very appealing to me, but that's what we do. So why is it that we had high rates of utilization of formula? If you think about the culture of poverty and people growing up, young new moms growing up in circumstances where they have very little in the way of nice things, if you're offering something that's relatively expensive to that young mom for free, is she going to take it? And is she going to use it? Well, of course she is. So the culture of poverty and WIC wound up leading to the highest rates of formula feeding in American Indian populations and other impoverished populations. So the populations that needed breastfeeding the most were getting formula. FDPIR, Food Distribution Program on Indian Reservations. That's the commodity food program. And when I was growing up, I remember it was grape juice, which I think was just sugar water with purple food coloring. And then there was, of course, sugar and flour. It used to be lard. I remember there's these big blue tins. And then they changed it to vegetable shortening, which is probably worse for us anyway. And then there was peanut butter. There's some sort of Spam-like meat product. I'm not sure exactly what that was. Of course, commodity cheese. Unfortunately, we all like commodity cheese. I wish we didn't, but we do. So now when we think of traditional American Indian food, what comes to mind? Traditional food. Fry bread. Did we ever fry dough, historically? No. Now, fry bread, the origin of fry bread is in the commodity food program. People doing the best they can with their commodities. I like this picture of the elder on the right. She's got commodity flour and commodity shortening, making fry bread. And now we call this traditional food. So much now that even when we go to a traditional ceremony or a feast or a gathering, there is an expectation that fry bread will be served. It's, I guess, comfort food for us now, right? But is it really traditional American Indian food? No. If we want to call it traditional, it's traditional USDA food. So we've acculturated that. We've brought it into our communities. So not only do we have these external forces that are creating health inequity, we have our own internal forces now. We embrace things that are bad for us. In addition to commodity foods, you know, there was a time when cigarettes were also distributed at no cost to tribal populations to get people addicted to nicotine. And now I see a lot of people using cigarette tobacco in their sacred pipes and praying with it. Now, what we would call tobacco is chinchasha, and it's primarily red willow. It's a blend of herbs, but primarily red willow. And we would use it for medicinal purposes. And we never chain smoked the sacred pipe. I always like to remind our traditional leaders that's not what we would do. But I see a lot of people using cigarette tobacco in their chanupa, or their sacred pipe, and praying with it. What would our ancestors think about that? We're using a poison and calling it traditional. Using a poison and calling it sacred. These are tough challenges and not pleasant or easy to think about, right? We have to examine what we are doing. Not just the external forces, but the internal forces. And we've been acculturated. We've adopted things that are now expected in our communities, like fry bread, and unfortunately it's now become a part of our modern American Indian culture. Next, of course, adverse childhood experiences. So if we look at the history, historical trauma, and boarding schools, one of the outcomes of that, and certainly we see in populations that are impoverished and have difficult social circumstances and deal with a lot of discrimination and being marginalized, is we tend to see higher adverse childhood experiences. And I'm sure many of you are familiar with the ACE study. It was originally done in California in the 1990s, but what they found is that the more adverse experiences in childhood, the worse the health status is during adulthood. And things like depression, anxiety, post-traumatic stress, substance abuse, suicidal ideation, and completion, much higher for children who have lived through adverse childhood experiences. But some of the more recent studies also show strong correlations between adverse childhood experiences and diabetes, adverse childhood experiences and cancer, and heart disease, and many of our chronic conditions. So if we are that third sister going upstream, from my perspective, this is the arena in which we need to be putting more effort into and addressing the needs of our children. And I'm sure many of you have seen the ACE pyramid, where adverse childhood experiences lead to impairment socially and cognitively, and certainly with neurological development. And then adoption of high-risk health behaviors, early onset of disease and disability, social problems, higher rates of dropout, higher rates of substance abuse, and early death. Now, when I see the list of things that adverse childhood experiences are correlated with, it's basically a laundry list of everything we're dealing with in Indian country in terms of the social circumstances and ongoing poverty, higher rates of dropout, higher rates of mental health conditions, higher rate of chronic conditions, higher rates of suicide. So from my perspective, this is the arena in which we need to be placing more emphasis. Well, unfortunately, it doesn't end there, right? We don't get through childhood and then all of a sudden everything is wonderful. We have a lot of challenges even in adulthood. And we see a lot of toxic stress in our communities. And we know that when we're under stress, there are all kinds of stress hormones that have a negative impact on our physiology. And the stress hormones can raise blood sugar, can raise blood pressure, possibly even be linked to cancer development and complications from cancer. And my sense of it is that there are probably dozens of stress hormones we just haven't even identified yet. So I don't know that we have a full science to really understand the impact. But then how this links to what we're talking about today is also the next generation of parenting. Children who grow up with adverse childhood experiences and are at such high risk for negative health outcomes and negative health behaviors, they become parents, right? Where do the parenting skills get developed in these circumstances? And this is a huge challenge. I see this in my own family, with the extended family and some of the challenges we face back in my home community. And we do see, unfortunately, higher rates of preventable diseases and preventable issues, and unfortunately, higher mortality rates. This was published just very recently, looking at counties and life expectancy. And you can see where the worst life expectancy generally tends to be in the South and in the Appalachian Mountains, except one place, Oglala Lakota County, my home county, among the worst life expectancy, not only in the United States, among the worst in the world. People in Sudan have a longer life expectancy than people from Pine Ridge. I was talking to the health director last year, and the average age at death for men from Pine Ridge is now 48. I'm 50, so I guess it's all gravy from here, right? You know, I hit my longevity, and now it's all, isn't that remarkable? So I'm also happy to be here at a world-class School of Public Health. And what I'd like to remind my colleagues and public health academics, you do not have to cross an ocean to find third world health conditions. We spend a lot of energy, a lot of effort, a lot of resources on international health, on global health, and that's wonderful. I believe in a world community. I believe we are all related. I believe mitakuye oyasi. But I also believe that my people need resources too. Our people need resources too. So it's one of the reasons we started the American Indian Public Health specialization at NDSU, is that we have programs all over the country, all over the world, focused on global health or international health. And until we started ours 5 years ago, no program was focused on American Indian public health. And I've told colleagues all over the country, if you want the curriculum, I'll give it all to you. I don't believe in intellectual property. I believe in the health of our people. And what if every university decided they wanted to adopt American Indian public health? And what if they put me out of business? Wouldn't that be wonderful? If everyone was competing to enter the space of American Indian public health, that would be a fantastic outcome. This is a study from a couple of years ago looking at average age at death in South Dakota. And I know it's a little bit hard to see, but in the yellow is the white population, the blue is American Indian population. And you can see average age at death for the white population in South Dakota is 81, and for American Indians is 54. Now that's including all population in South Dakota, including the urban populations. So what can we do about this? I was a co-principal investigator on a project called the South Dakota Health Survey, and the goal was to include all counties, including all reservation counties. And we engaged all 9 tribes in South Dakota, and 7 of the 9 tribes, including my home community, agreed to participate. So we worked with the tribal IRB at Oglala Sioux Tribe a number of years ago to get formal approval to do this, as well as the other tribes. So we wound up having a little over 8,000 survey respondents. Of that number, 520 were American Indian. So we did oversample tribal populations. In this study, we included things like screening for mental health conditions, self-reported chronic disease, self-reported health status, and also the ACE questionnaire, adverse childhood experiences. In terms of mental health screening, we saw higher prevalence of risk for depression, anxiety, and post-traumatic stress in the reservation populations as compared to other populations within South Dakota. In terms of self-rated health status, and we stole this questionnaire right from Burfus, actually, so it's a validated question. But you can see in the reservation population, self-reported excellent or very good health is much lower, and self-reported fair or poor health is much higher for the reservation populations. When we looked at alcohol use, we did see higher prevalence of binge drinking in our populations. But one of the things that I've seen in all of our populations, and in truth, all of our data sets, is that not only do we have the highest prevalence of binge drinkers, we have the highest prevalence of non-drinkers in Indian country. And when I think about my family, I think about my community, there are so many people who won't even touch alcohol. They've seen the devastation that it occurs. So we could look at this data set and say American Indians have a problem with alcoholism. Or we could look at the same data set and say American Indians are the most sober population in the country. Because we are. Now, what is it about this segment of the population? What is it about the resiliency of this population? What is it that we can tap into to promote health and not just focus on the disparity? But what is it about many people in our communities that provides them that strength to overcome these challenges that are pushing towards self-medication, but they're not doing it? That's a lot of strength within our communities, and I think a lot of untapped strength. Unfortunately, for adverse childhood experiences, significantly higher on average for American Indians, and there's actually 10 domains within adverse childhood experiences, including abuse and neglect. And you can see the numbers for abuse and neglect, unfortunately, much higher for American Indians. This will be published actually later this month in the Journal of Healthcare for the Poor and Underserved, which is actually sponsored by Johns Hopkins University as well. But these results will be published this month. In terms of household dysfunction, look at the one on the left, mother treated violently. What we're seeing, and I'm sure many of you have seen this in your own communities and in your own data analysis, is that children who witness violence are at just as much risk as children who experience violence directly. So this is an arena, when we're talking about fatherhood and families, we need to re-engage our traditional approaches to parenting and to fatherhood. The only way to do that is to address all of the social circumstances that are having an impact on violence in the home. And I'm so happy that we did get the Violence Against Women Act reauthorized in 2013. The challenge there is that quite often we don't have the resources in our communities to enforce some of the things that are in VAWA. So the Violence Against Women Act does give tribal systems the right to prosecute, but then we also have to have the resources for public defenders, we have to have the resources for health services for the offenders. Not all of our communities have those resources. So it's a step in the right direction, but we still need more resources to make it fully effective. And one of the studies I saw recently in the upper Midwest and the Northern Plains is that the majority of women being treated violently are being treated violently by non-Indian offenders. So we also have to look at this whole social dynamics within our communities. Because not only is that woman at risk, the children witnessing it are at high risk as well. And you can see household substance abuse, household mental illness, parental separation or divorce, or incarcerated household member tend to be higher for reservation populations. I think when we look at the future of the adverse childhood experiences, we also need to think about some American Indian specific questions. How do we measure the impact of historical trauma, for example? We also look at incarcerated household member. We have the highest youth incarceration rate. Maybe we should ask, were you incarcerated as a child? And then parental separation or divorce, again, framing it from the nuclear family perspective. Do we have some of our children being raised by grandparents or aunts and uncles? Actually in healthy homes, absolutely. So there are some things about the ACE questionnaire that I think could be probably more culturally relevant as well. So significant challenges, high rates of poverty, unresolved trauma, politics that are limiting our access to resources, quite often inattention to our issues and neglect of the challenges that we are facing. And unfortunately, racism is alive and well. It's been that way, growing up in South Dakota, it was terrible. It's getting a little bit better, but ironically now in North Dakota, it's getting a little bit worse because of the pipeline backlash. Some of you might be familiar with that. So we see inequity across all sectors, income, education, health, etc. And the outcomes are poor health status, more disparities, more inequities, generational poverty. And we almost grow up with a culture of poverty now. Poverty frames what our young people believe is their future and what is possible in their future. And then just, of course, ongoing inequities, suffering, and early death. We're seeing that in our communities. We have to work upstream, and we need to address it in a comprehensive way, not just from the medical side, but also behavioral health needs to be integrated with public health and social services. And when I look at some of the challenges that we're facing in our communities, again, it's not an issue that we don't have enough medication in the pharmacy. It's not a medical problem. It's a public health issue, and it includes social services and social outcomes. So for future directions, what I'd love to see be expanded upon, and certainly we'll hear more about the Family Spirit Program a little bit later today in terms of a randomized controlled trial that shows effectiveness. But I really believe that the future for preventing things like adverse childhood experiences includes home visitors and community health workers. Our big challenge on the policy front is that typically those are not billable services, right? So we could do this work when it's a grant, but then if we can't make it sustainable, the grant goes away, the program goes away. That's not going to create a long-lasting impact. So we also have to have policy warriors, right? People that are willing to fight for these things to be reimbursable. So it's remarkable to me we won't invest in paying for community health workers under Medicaid, for example, but when that child has uncontrolled substance abuse and chronic disease, we'll pay for that. So again, we're that first sister dealing with the crisis, We're not being intelligent and working further upstream. And I also think parenting skills needs to be a part of this, but also recognizing that parenting skills of a community, not just individual mother and father, but entire generations. Again, historically, the aunts and uncles would be raising the next generation, not just a nuclear family. That's a foreign concept. And certainly embracing our traditions. There's nothing traditional about child maltreatment. In Lakota, we call them spirits. Our children are spirits. They're right from the spirit world. What a miracle that is. And we have to recognize that we have to focus on preventing adverse childhood experiences. But what about those who've had adverse childhood experiences and are dealing with the outcomes now? We can't forget about them either. So we have to mitigate the impact. There's a real promising program called Stress Management and Resiliency Training out of the Mayo Clinic. Some of you may be familiar with this. And we put forth a grant to NIH, hopefully to study the impact of the SMART protocol in tribal communities. It's never been done before. It's a evidence-based practice in the Mayo Clinic, but it's never been done in a tribal population. We're trying to get that done. It's been hard getting NIH funding for a lot of these things. It's not basic science, it's applied. So we have had some challenges there. But why not use an evidence-based practice, modify it to be culturally relevant? Part of the SMART protocol includes a daily Thanksgiving or daily gratitude. That's like morning prayer, right? So this can be framed in a culturally relevant manner. Also, cognitive behavioral therapy, what's being done in the VA, I think, is very promising as well. And we could expand upon this, but again, we need the resources to do so. And I had to throw in a picture of my son. He's 11 years old. That's him on Earth Day, and makes me feel positive about the future, that this work that we're doing is meaningful. The work that we are all doing collectively is sacred work, and we have to recognize that it's for our future generations. And I always like to close with this saying from our Blackfeet brothers and sisters. A child is sacred, and when that child comes into the home, the family must welcome it. And if the child is happy and feels the want, he will come into this world very, very strong. And not to know this is to know nothing. And not to know this is to know nothing. We have a lot of work to do. We have sacred work to do. And the beauty of our opportunity is this little miracle of now, when the past is meeting the present. We can't do anything about the past, but what we do right now can change the future. Let that be our call to action, and let's make sure that future generations live in a happier, healthier way. Palama Yolo, mitakuye oyase. Thank you all very much.
Thank you so much, Dr. Warren. I hold in my heart the idea that public health is traditional medicine. And, this school claims to be the oldest school of public health. It's just a blip on the screen when it comes to what tribal communities know about public health. Please get out of your seats and ask Dr. Warren questions, because he's a font of wisdom and information. We want to ask you, if you do have a question, to please use the microphones on the sides. I neglected to tell you that this is being live streamed. There's people all over the country who are listening today, so let's talk to them too.
Yes, if there's any questions or comments, or rumors, innuendos, tall tale. There's a microphone over here. Yeah.
Good morning, Donald. I want to acknowledge your words. I am a tribal health director from Shoshone-Bannock tribes, and I can't say enough for the work you're doing. And we do need more public health schools for our Native Americans, and that's one thing I heard. And back in our community, I serve on the Portland Area Indian Health Board, and one of the things we talked about is the shortage of doctors, nurses across Indian country. and public health because it's so important. But I just would like to hear more ideas on how to grow in our own communities, because we do have this population that's older and they're retiring, and we have the new people coming up. So I'm looking for ideas as well and help in those areas, and I really thought your presentation was right on and very interesting. And we do need to grow families and support those efforts in health. So I just wanted to acknowledge you for those wonderful words of wisdom.
Well, thank you so much. And I agree, we also need to build the stream of new public health professionals in the next generation, both in medicine, but also public health, nursing, all of those disciplines. And one of the things that we've been doing out of NDSU is we also offer an introduction to public health course to the tribal colleges through distance education. So we use interactive video. But that's at the tribal college level. We need to be even further upstream. So I think within the sphere of influence of what we have at a university, we need to be engaging other partners to make sure that everyone knows that they have opportunities for healthcare careers in the future. So thank you very much.
I just want to say one thing, the hope for the future. We have Justin Jones from the Tlingit tribe in Juneau, Alaska. And Justin's been accepted into the Masters of Public Health program here at Johns Hopkins. So for Johns Hopkins people, if you have words of wisdom for him, if you want to offer him scholarship money, please come up and say hello.
Great. Dr. Carroll had a question. Yeah.
Oh, good, thank you. Good morning, everyone. I'm Susan Carroll. I'm a former CMO for IHS. One of the things, Don, that I totally love your speech is the work that has to be done for health equity. It is enormous. IHS is IHS is IHS. It's been that way for 50 years. It's going to be a long time before it really turns around, I think. But I think as a federal employee, I'm now with CMS, you have to look at the other side of the coin for transportation issues. I was at Pine Ridge many times last year. The roads were horrendous. The schooling, the Department of Education has to be involved. And I can go on and on. But I think your slide deck is great. I hope everybody takes it home and spreads it around the country. But that part, health equity, we have to focus on. Just like to hear your comments on that.
Yeah, and it's interesting because we, in public health, have kind of adopted the phrase health disparities, right? That we want to decrease disparities. But when we say we want to decrease disparity, we're actually speaking in a double negative, right? Decrease disparity. What we want to do is promote parity. We want the health of one population to be on par with another. The challenge within our systems is that we usually take a one-size-fits-all approach. And the package of services that might be effective for people in Baltimore might not be effective for people in Kyle, right? So we have to also look at individual community dynamics and recognizing that social circumstances and the social context has a huge impact on how effective our programming is. So it's more than equality, and it's more than just parity. It's equity and understanding that there is a social justice imperative to promote equity. And the best example I ever heard of the difference between equality and equity is that equality would be like giving everyone a pair of shoes. Equity is giving everyone a pair of shoes that fit. And we take the one-size-fits-all approach too often. And as American Indian people, we're left behind in that approach. So we need to be smarter than that in health systems. And for me, that's where equity plays a prominent role, is ensuring that we meet the needs of individual communities, not just meet the needs of the system. Yeah. But I know I'm at my time limit, so oh, yes, go ahead.
No, I'm not going to turn down this opportunity. You know, Dr. Warren, I'm so honored that you come here today, and we were chatting earlier, and when I saw that he was the keynote speaker, I said, "Are you a Head Start graduate?" He said, "Yeah, I'm 50, he said. So here's an example, folks. I just retired from 34 years with the Office of Head Start, and all the things that you've talked about here today has been on my heart and mind all that time, and I have colleagues here in the room, that we have actually engaged in many initiatives, such as you've identified today, that would continue this great work today. And a great part of that is like a journey. You know, I think back, the Great Spirit brought us together. And so what is the next, as you said? We can't do anything about the past, but we certainly can do something about the future. And all of you in this room today have a golden opportunity to be joining that team of effort of making that a reality. And I'm so thankful and grateful that you are here today, and those that are, as Alison said, this is live stream. I've never been live streamed or anything, but whoever you are out there, you know, that is our mission, that is our purpose. It's for us to take what Dr. Warren has shared with us here today and continue to move forward. And it's all about the family. And thank you so much for being here. And Dr. Warren, I'm grateful for whoever enrolled you in Head Start.
Good way to end it. Thank you very much.
Thank you so much. That was wonderful. So as you looked at your agenda, we have 3 panels today. Each panel will be moderated by a different expert. And Amy's our first moderator. So if we can ask Amy to come up. And then I'd like to ask the speakers for panel 1 to please come sit in the front row if you're not already, over by Mr. Cooley here. And Amy will have each come up. Afterwards, there'll be a Q&A, and we'll ask our speakers to sit up in the front and face the audience so they can engage with you. Thank you.
Good morning, everybody. My name is Amy Fatwafe, and I am the director over at Native American Fatherhood and Families Association, so it's an honor to be here today and to see all of your smiling faces. I'll be the moderator for the first panel. I'd like to introduce, as you guys can come up, Al Cooley, as well as Ann Bullock and Anita Finday. And we'll start with, if you each want to come, maybe have a seat. Okay, go ahead and have a sit in the front row. Do we have Anita here too? Okay. Well, as they're coming up, I'm going to go ahead and introduce them. Al Pooley, Albert M. Pooley, he is the president and founder of the Native American Fatherhood and Families Association, located in Mesa, Arizona. He has dedicated his time, education, resources, and passion to help develop and bring awareness to the various Native American tribes and individuals who have an interest in preserving Native American cultures, traditions, and history. Mr. Pooley conducts classes, trainings, and seminars, all of which an emphasis on strengthening the Native American cultures and family unit. Mr. Pooley is highly successful in his hands-on approach to educating youth, adults, elders, as well as Mr. Pooley has received his MSW from the University of Utah and a Master's in Public Administration from the University of Denver. He has been married to his wife Julia for 47 years, and they have 6 children and 16 grandchildren. Mr. Pooley extends an invitation to all in both the Native and non-Native world to learn more about Native American Father, to learn more about us. He encourages you we're excited to listen to him and to hear what he has to say. So we'll go and start with Mr. Pooley, and we welcome him.
Again, welcome. I forgot to overlook this morning Casey for putting this on. I really want to tell you thank you very much, and for all the hard work you've done and all the good work you're doing. As was mentioned, what happened was that I'm a little bit more about who I am. I'm really trained as a marriage and family therapist. I've been doing that since 1971. And I've focused primarily on working with Native families. And back in 2001, I'll tell you the story. I got out of the counseling business for a while, and I went into textiles. I used to make like the Pendleton blankets and things like that. And I'd use only wool from the reservation, Navajo reservation. And I started going into things like apparel, coats and jackets, and I was selling to companies like Lord & Taylor, Bloomingdale's, Marshall Fields. But you know what? I went broke. And I lost my house. And one morning, there was two gentlemen standing in front of my, knocking on my door, and they says, are you Mr. Cooley? And I says, yes, I am. They said, well, your house went into foreclosure, and we're the new owners of your house. Well, I was really surprised and went and talked to my wife, and she wasn't very happy. And she said to me, you better go back to work. You do what you know and forget about textiles. So I took my family, we had to move to another location. And I went to a friend of mine who, his name is Bob Lewis. He was the director of social services for the Salt River Tribe. With my tail between my legs, humble pie, I went to say, hey Bob, do you got any work for me to do? And he said, well, I thought you were in textiles. I said, well, I am. I said, I was, but I no longer. I went broke. And he says, yeah, I can have you. I can use you. And he said, what are you going to do? I said, just give me your worst clients. And he said, okay. So he gave me a whole bunch of men. And to make a long story short, if I didn't go broke, I would have never started the Native American Fatherhood and Family Association. We started with one father on the Salt River Indian Reservation, and today we work with 207 tribes throughout North America. We have programs from Maine to Hawaii, from Alaska to Florida, and we've done this with no federal funds, with no state funds, with no private foundation funds. The tribes are actually buying the services on their own. So it is connecting with some people. We are in education, we're in social services, we're in behavioral health, we're in education, we're in criminal justice, we're in a lot of fields. And we'd like to have, and I'm glad you're here to learn about our program. Now you're gonna have to do this, Amy. Tell me when I got 5 minutes left, okay? Because my wife, if she was here, she'd go like this, you know, cut me off. Anyway, yeah, somebody has to do that, yeah. But anyway, we said, I have learned over the years that knowledge rarely changes people. But yet most of our programs are what we call knowledge-based. But you can tell a person, you know, you shouldn't drink, you should get a job, you should take care of your family. And what they'll say, I know, I know, I know. People do know what they have to do. They really do know. But when you engage people, we're in the people-changing business, I tell people. That's the business we're in, to change people's lives. But you know what? I do not, nor do you, have the talent, the skills, the knowledge to change anybody. But yet that's our business. So how do you change people? Well, first of all, I feel you have to make them feel. You really have to make them feel. Now let me have Monty come up here for a minute. Where's Monty? Is he in the room? Oh, there he is right there. I want to pick on him. Okay? Now, we all know who Monty is. You all have to admit now, tell me something. This guy is handsome, and see, isn't he? He's strong, he's tall, man. Okay? Now, let me ask you something. Are you married, Monty?
Yes.
Okay, what's your wife's name?
Pam.
Pam. Do you think Pam would have married this man if he just gave her a copy of his resume? What do you think?
Yeah.
She would have. Okay. Most likely she might have been impressed, but she would have never married him. But what if he gave her a copy of his resume and letters of references? Would that have helped out? Yeah, it would have helped out a little bit. She might have not been impressed, but now she gave her his resume, letters of references, and pictures of himself. Even with one, just with a Speedo one. Would that have done it? Now, no. She probably would have now still not have married him. What this young man had to do, come here, Monty. What this young man had to do is this. He had to make his wife feel. He had to make her feel. He had to make her feel welcome, wanted, needed in his life. He needed to make her feel special. Am I right? Mm-hmm. Thank you. Now, you're in the people-changing business, and I am too. You have to make people feel. Knowledge will not do it. Knowledge will not do it, I promise you. Now, so when I tell people, when you're in the people business, particularly if you're in the Native American people business, your number one job is to do this. You must truly love the people whom you serve. I've taught at 3 universities in the past. I've taught at the University of Utah, I've taught at Metro State College in Colorado, and I've taught at ASU, School of Social Work there in ASU. Every one of those institutions pushes away from the word love. You can't love your clients. If you're in the Indian business, you better love our people or get out of the Native people business. Now, number 2, you must truly love what you bring to them. Do you love what you bring to them? Now, let's pick on a mother. Any mothers in this room? What's your name? What? Kiana. For her to be a good mother, and I'm sure you are, has your baby ever throw up all over you? Did you say, oh, I just love that when my baby throws up over me? No, but she has to do the good and the bad, right? Now, she must, when she loves being a mother, she will clean up the mess, okay? Because she loves her children, loves being a mother. Now, when I was in direct practice, I didn't like a lot of the things I had to do, but I had to do them because that's part of my job. So if you're going to serve our people, you must love what you bring to them. Now, precisely, this is what you do next. Precisely, you do this. The first thing you must do is uplift them. We just had a great presentation about Dr. Warren's presentation. I loved it. Our people need to be uplifted, particularly by our own people. A lot of times our communities are filled with gossip, rumors, and lies, and we push people down. We have to uplift people, make them uplift their spirits, uplift their attitudes, uplift their self-worth. You make them feel welcome, wanted, needed. You make them feel special. After you uplift them, you encourage them. You strengthen the hope they bring to them. Because a lot of people, all the time, all they have when they come in to see us is just a little bit of hope. You have to give them new hope. But that hope that you bring to them must be grounded in truth. If it's grounded in lies or deception, people really jump off the edge. The next thing you must do, you must assist them in a lot of things. Help them identify resources, help them identify things. But when you assist them, you actually help them solve problems. I tell people all life is, every day of your life, every hour of your life, you're going to have to do this. You're going to have to solve problems. Every single hour, every single day of your life. That's all life is one continuous process of solving problems. Now, the moment you stop solving problems is the moment you now become the problem. You in the health services business, you know what I'm talking about. So you help people solve problems. You know what? When you solve problems, that's a sign of maturity. You are becoming mature. You're becoming responsible. And when you do this, when you love the people you serve, when you love what you bring to them, when you uplift them, when you encourage them, when you assist them, now guess what? They're all ears. They will listen to you. Because not only do they trust you, but they have confidence in what you do and what you bring to them. Our program is called, we have 2 curriculum. One is called Fatherhood is Sacred, Motherhood is Secret. Now, like I said earlier, the heart of our Native American people is family. Because of that, being a parent, being a father and mother is personal. It's a personal thing. You have to embrace yourself. And that's one of the hardest jobs you'll ever do in your life, is to being a father or being a mother. Do we have any single parents in this room? Stand up. I'm going to give you, stand up. Single parents, stand up. Okay. I start by, if you're a single parent, understand, these people that are standing up, they're today's true heroes. Thank you, sit down. Because they're doing a job that requires 2 adults, full-time adults, to raise a family. And you're doing it on your own, you are today's heroes. Do you have any grandparents in here raising grandchildren? Anybody? 1, stand up. 2, If you're grandparents raising your grandchildren, here's another bunch of true heroes of today. Thank you. Sit down.
I want to make a correction because I am a single mom, but my parents helped me.
Okay.
My family, I mean, I couldn't.
That's fine. That's happened a lot. As long as you're a single parent, you're welcome to stay well, and grandparents. Now, I'm turning 70 years old here in a few more days. I couldn't raise my grandkids. I just couldn't do it. I could try to, but I don't have the energy. I don't even know how to do these darn things on the computer. I don't know how to do all that kind of stuff. Ask my kids, they'll tell you. Raising children is a responsibility of two parents. And if you're doing it on your own, you are today's true heroes. I mean, really the true heroes of today. Or if you're grandparents raising your grandchildren, you are today's true heroes. Why do we call our programs Fatherhood is Sacred? Let me tell you why. Sacredness, Native people know what that means. They say, we talk about sacred things like rivers and mountains and canyons and burial grounds, even some animals like buffaloes and eagles. Those are sacred to us. But we have missed the mark, I tell people. We have really missed the mark. Let me tell you a story, what I mean by that. Back in the 2000 Olympics, 2001 Olympics over in Athens, Greece, there was a guy named Matthew Emmons. He was a marksman, and he already had won 2 gold medals and was going for his 3rd gold medal. And he got up to shoot, and he shot bullseye. Oh, the crowd went wild. Then the field judge had a flag, white flag, stop shooting. He says, "What's wrong?" "You're disqualified." "What do you mean I'm disqualified? I just shot the bullseye." "You did, but you're standing in lane 3 and you shot the target in lane 2. You're disqualified." Mr. Emmons was so mad at himself, so upset, because he was disqualified. Why do I tell you that story? Because so many of our Native people, we understand what sacredness is. Everything is sacred except we have neglected to identify two of the most sacred things on this earth. That is your job as a father and your job as a mother. We have found that when people really understand that, here, not up here, but here, you know what? They are easier to work with. They're more self-motivated to change their lives. You're making them feel the importance of their role as a father and their role as a mother. We say this to the fathers and to the community. Let me back up a story. I was with a tribe in the central, there in Oklahoma one year. And I tell the people this: Native American men make great fathers. They make great husbands, and they make great leaders. Our Native American men do that. After my presentation was over, this one woman comes up to me and she says, "Mr. Cooley, I enjoyed your speech, but I don't agree with you on one thing." I says, "What is that?" "You said Native men make great husbands and great fathers." She says, "That's not true." She says, "I've been married to 5 of them. And they were all no good." Well, I thought to myself, how are you picking these guys? Would you take some responsibility for that? Now, Native people understand the sanctity of certain things. And I said, let's go back and do this. Let's say in some way we could have all the eagle feathers, prayer feathers held by our great war leaders and our spiritual leaders for the past 500 years and somehow stack them in this room. Oh, these would be treasured. We probably wouldn't be able to touch them. This was held by Sitting Bull, Tecumseh, Geronimo, whoever. These are great feathers used by, and then you bring a mom and dad and you put them next to these eagle feathers. And then you bring their kids inside. I say, "Now, kids, these are all the great eagle feathers held by our great Native leaders for all these years." So they have a good knowledge of what they're looking at. Then you say, "Now here's your mom and dad. Would you rather have your mom and dad, or would you rather have those eagle feathers?" That always pick their parents. Kids know the sanctity of what is really of value and as a worth, and that's their father and mother. In our programs, we say this: fathers, understand this. You are not the problem in your communities. You may have been identified by people or agencies as being the problems. But in all reality, you're not the problems. You are not the problems. You are really the answers to address our problems in our communities. Number two, fathers, your job is to do this. Your job is to keep your families together. And you're the greatest untapped resources in your community. We have to understand, we are paid to engage them. But most people don't know how to engage fathers, so they just push them aside. We have to make an effort to engage the men in our programs. You got to make them feel welcome, wanted, needed, and special. We have found Native men make great fathers. And today, in fact, a lot of our fathers today, the wives are turning the kids back to their dads. It's becoming a very normal process. I want to explain to you also that we say, fathers, you are the leaders. What is fatherhood? Fatherhood is leadership. What kind of leadership is it? It's the most important kind of leadership you will ever do in your life. Now, if you're the leaders of your family, we say this, fathers, and we also define the purpose of life. We say the purpose of life is to have a happy and safe family. Not just to have a family. Anybody can have a family. We want our Native families to truly be happy and safe. We tell the dad, you're the father. Your job, your number one job is to bring happiness and safety to your family. That's your number one job. And this is where you start, dads. This is where you start. You start by bringing happiness and safety to your dear, dear wife. Why? Because your wife is your full and equal partner. I have never met a woman that got married with the understanding she was going to be a limited partner or, heaven's forsake, a silent partner. She signed up to be a full and equal partner. But what? When the father takes the initiative and the lead to bring happiness and safety to her and the family, you know what? She's supporting him 100%. But a lot of our Native men take more time in bringing happiness and safety to their own mother. Now, wonderful, your mother brought you into this world. She loved you. But your mother is not your full and equal partner. She's your mother. We have a lot of guys that are babies. They're mama's boys. You take the responsibility of bringing happiness and safety to your family. And your kids will love you for it. But that's what we tell them. You know what? We say, that's the real Native way. Many times, I go to a lot of prisons. I go to a lot of prisons. And they call themselves warriors in the prison. You can't defend anybody here in the prison. I was over in Bismarck, North Dakota at the prison there. And there was a nice place. They even had tablets. And it was really a brand new prison in North Dakota. You've been to Bismarck, North Dakota? Yeah, nice prison, isn't it? I mean, you've been in prison, but you probably visited the prison, right? Not in prison. But I was in Bismarck, North Dakota last year. And I got to see all the prisoners, all the Native prisoners. It was packed. I think about 50% to 60% of the prisoners were all Native Americans in North Dakota State Prison. And they were all, I was happy to see them. I said, what are you guys doing in here? A month prior to this, there was a little boy up there in Newtown, on that reservation, that froze to death. You need to understand, you have a response. By being in prison, you can't help anybody. When you get out, you must make a commitment to go and strengthen your people. Now, and you start by, first of all, by strengthening your own families. Now, I like your presentation, Dr. Warren, because you said about learning. And I like the idea you said, learning the truth. If you're really going to learn, we tell our fathers and mothers this, you must have a real desire to learn the truth. Because let me give you an example. If you were taught by your mother, your grandfather, your aunties and uncles, if you were taught that 2 and 2 equals 3, and 3 and 3 equals 5, and you believed it to be true, you would never be a math teacher. You will never be an accountant. You'll never be a banker. You'll never even balance your own checkbook. You have to learn the truth of mathematics. The other thing is this, let me give you another example. I tell our people always look beyond the box. Because for hundreds of years, literally hundreds of years, people believed this, and it was taught by their educators. It was taught by their spiritual leaders. It was taught by people all around that the world was flat. We know today the world is not flat. Our forefathers had the wherewithal to realize, hey, maybe the world isn't flat. They took the initiative because the world really isn't flat, or we wouldn't be in this hemisphere. You must learn the importance of learning the truth. And we tell this to the parents. Fathers and mothers understand this. It is one of your sacred responsibilities to put the desire to learn into your children. That is not the responsibility of the school. It's the responsibility of dad and mom to put the desire to learn into your children. So when a kid goes to school, the desire to learn is already there. The teacher, all they do is that they enhance that desire. They don't put it there because dad and mom have already put it there. Now, there's some things that prevent us from learning. One of them is fear. When you have a lot of fear, you know what? You don't learn very much. Another one is loneliness. When you really feel alone, what I mean by loneliness, you don't connect with too many people. You feel like you're all alone. You know what? You don't learn very much either. When your life's in chaos, you don't learn very much either. Another way you don't learn very much is when your self-worth has really been hurt. You have a low self-worth, you don't learn very much either. I can give you a list of things that happens when a person doesn't learn. It is a responsibility of fathers and mothers to do everything we can to uplift our people. That's why I tell the directors of the programs, when a client comes into your office, the first thing you must do is you must make them feel welcome. Smile at them. Make them feel welcome. And if your secretary or receptionist does not know how to smile, I don't care if they're the chairman's daughter or wife, put them in the back room until they learn how to smile and greet people and make people feel welcome. That's critical when you work with our people. Now, getting into this, we teach the people the part about learning the roles of fathers and role of mothers. We have had, let me tell you one experience. One of our fathers was in prison, in San Quentin prison. No, excuse me, in Folsom prison. Folsom prison. Oh, thank you. She read my mind over here. Thank you. He was in Folsom prison, and he came to our program, and he started to improve slowly, slowly, slowly. Let me tell you why. Because truth comes slow. It comes slow. Have you ever seen a woman, for example, or a man in a very domestic violence situation, and they know about what's going on? Let's pick on a woman for a minute, or man. Let's say this guy cheats on you. He lies to you. He steals from you. For years, this goes on. You know something's not right, but you put up with it. Finally, one day, it clicks. I got to get out of this relationship. It may take somebody 10, 15, 20 years for them to really absorb the truth, because I tell them, when a person does that to you, they don't have respect for you or the relationship. You must learn the truth about your own self-worth, your own value. It's critical. Now, I want to leave a little bit for a little bit of time for questions if you have any questions. But one of the things we work with the fathers on is also on their attitudes and their self-worth. Because we say this, there is nothing in this world that will have more direct, immediate impact on your happiness and success in life than your attitude. Not your looks, not your wealth, not your education, not your gender. Nothing will have more direct impact on your happiness and success in life more than your attitude. And some people, pardon the expression, they have a very, very bad and poor attitude, and they wonder, what's the problem? I'm sorry, but you're the problem. You worked with people like that in the past. So we work on parents to have good attitudes to uplift them, each other, and their children. Now, I could go on, believe it or not, for a long time, but my time has been told me that. I want to give 5 minutes. Do you have any questions you want to ask me for? Oh, questions at the end. I can talk for 5 more minutes. Oh, that's good. Okay. Yeah. Now, we talk a little about historical trauma, but we say this. If you really want to pay back your forefathers, people, if I took an inventory here, let me ask you this. How many of you people in this room would love to have your kids, your children, have greater opportunity than you did and have more happiness than you did as you're growing up, more than you, have a better life than you did? Raise your hand. Everyone raises their hand. That's the same thing our forefathers felt. They sacrificed, they suffered so many things. Why? Because it was for their families. They wanted their families to have a better life than they did. I tell them, if our forefathers were here, they'd say this. We know what fear is. We know what pain is. We know what sorrow is. We know what suffering is. But we did it for you, our children. If we're going to pay back our forefathers, really pay them back, we must improve upon the present. That's how we pay them back, by becoming good, decent, honorable men and women, because that's where we come from. We tell the fathers this. Mothers, I want to tell you where you come from. You come from greatness. You come from a great people, a great culture, a great heritage, a great history. If you come from greatness, people, it is your job to return your family back to becoming a great people again. That's your job, dads. But this is where you start. You first of all got to become a good person first. You become a good, decent, honorable man, and let me tell you, you'll see changes. One thing special about women, we tell the fathers this. The strongest thing on this earth, is the heart of a loving and caring mother. There's nothing stronger than that. When you really have cared for your children, if there's a fire, the mother would be the first one to go in that fire to save her children. How can we even think of hurting our mothers and our women? Because we tell them this. The greatest creation of the Creator, is not the earth, not the sun, not the moon, not the ocean. The greatest creation of the Creator is womanhood. Why womanhood? Because it is through the woman that life is renewed. It is through a woman that life is sustained. It is through a woman that life is beautified. Ever been into a man's apartment with no woman in there? It's just a TV remote control. You bring a woman in there, she put pictures and flowers and everything else. We never tell a man not to hit their wives. They know that. We want them to appreciate their wives. We want them to be grateful for their wives, because the old Indian medicine is this: gratitude. If you're really grateful, we tell them, you're just smart. You're just flat out smart. A grateful man is a smart man. Another one is humility. Let me tell you what I mean by that. Years ago, I used to herd sheep. I used to hate herding sheep on the reservation, but I try to hide from my grandmother, but you can't hide from Grandma. She can smell you if you want to. You can't hide from her. And I used to herd sheep every morning and every evening. I just found bow-legged, because I rode horses every day. I really did. And one day I heard my grandmother, early in the morning, she was praying. She had her cornmeal, corn pollen. It was called chadatin, and that was what it was called. And you pray for the sun coming up. And she was praying. What she prayed for, gave thanks for? I thought she wasn't playing with the full deck for a while. I really did. She gave thanks to the Creator for the sunlight. Who thanks the Creator for sunlight? She thanked Him for the air we have to breathe. She thanked Him for the water, for the food, and for the earth, Mother Earth. That woman, like I said, I thought she wasn't playing with the full deck when I was a kid. I realized today she understood her nothingness without the Creator. That's humility. She already understood the importance of family. That's why she do things for her family. We got to bring the old ways back. We got to bring those ways back, because our people knew a lot. They really knew a lot, and they were grateful. They were a grateful people, and they were a humble people. I tell people, when you turn on, is there a way you can turn off the lights in this room? Can you turn off the lights in this room? Anybody? You can't turn off the lights? Okay. Leave them on. Okay. If we could somehow turn off all the lights in this room, you know what? It'd be pitch black in here. And I say, walk around this room, it's a matter of a few minutes before you hit somebody or knock something over or bump into something. You turn on the lights, you can see. You can't see color when it's dark. When you really are grateful and humility, you know what? That flips on the lights in your life. You can see things. I'm saying, I'm teaching you what you already know. It's Native American 101. That's all it is. You can heal yourself. You really can. One last question. Have you ever known someone that's just bitter? Not eating bitter root, I mean just bitter. Some people just complain about everything. Understand one thing. The people that are bitter are not grateful. They think somebody owes them something or they're entitled to something. You're not entitled to nothing. Fathers, it is your job, and I want to encourage everyone in this room to believe in your men, to believe in the fathers. They're great people. They do make great fathers, great husbands, and great fathers and great leaders. Thank you for your time.
I want to thank you, Mr. Cooley, for presenting us. No, we're doing questions after.
Oh, okay.
Sorry, just for a little confusion for the people who are coming up, we'll do all the people on the panel first, and then at the end of each person speaking on the panel, then we'll have them come up here and sit down, and that's when the questions will be. So next will be Ann Bullock, I'm sorry. And she'll be speaking on the early roots of health, so go ahead and come on up. Ann, and while Ann's walking up, I'm going to introduce her. Ann Bullock is a board-certified family physician who has worked for the Indian Health Services for over 26 years. She served in various clinical and administrative roles in the Eastern Band of Cherokee Indians in Cherokee, North Carolina from 1990 to 2009. Since 2009, Dr. Bullock has worked for the IHS Divisions of Diabetes Treatment and numerous IHS diabetes treatment guidelines, clinical tools, and best practices. In addition to diabetes, Dr. Bullock's interests include the effect of chronic stress, trauma, historical trauma, as well as poverty and food insecurity on risk of chronic disease and other adverse life outcomes. So welcome, Dr. Bullock. Thank you.
Good morning. So as I was listening to Dr. Warren's great talk, I was thinking, oh, gosh, I don't have to give this one because it's going to be very similar. But then I got thinking about it, in the midst of panic, going, well, actually, a number of us, and Don is certainly among those, we've been talking about this for a lot of years and trying to think about it, and it's so fabulous that we are now finding that we are talking very similarly about where the issues are. We're starting to kind of figure it out and where the directions are that we need to go. And that is a very exciting kind of thing. Because it's simple but not easy, right? The three main things come down to decreasing stress and trauma for parents and young children. Thanks. Increasing protective factors for parents and young children, because sometimes it's about making the bad things less, but sometimes it's also about making the good things better, because it's that balance of those two. And the third thing is, and I won't have a lot of time to talk about it, but the absolute importance of nutrition. So we'll talk about that a little bit briefly. But as Dr. Carroll pointed out, IHS, we have some challenges, but I also want to say there's some remarkably good things happening, and I want to talk about not just IHS as the federal agency, but our IHS tribal and urban partners in health. And I want to, of course, the program I know and love best is the Special Diabetes Program for Indians. And because we've been looking at this science for a long time, we've been talking with our grantees and amongst ourselves in this national conversation about how important it is to look at the context for obesity and diabetes and how adverse childhood experiences and food insecurity and all these things play hugely into them. And to change that unfortunate medical culture of blame and shame for patients with obesity and diabetes and looking at it in this larger context. And that's a conversation that our grantees, our 301 SDPI grantees across the country are already on board with and excited about. And we've encouraged and allow through SDPI, because of the science that Don talked about, I'll talk a little bit about, that they are allowed to select home visiting, evidence-based home visiting, as an intervention that they can use their SDPI dollars on. SDPI is about diabetes prevention and treatment. This is about diabetes prevention and treatment. Also to incorporate issues around food insecurity and traditional foods, which is a wonderful melding of those two issues happening around Indian country. So these are exciting things, and I do want to also mention that we are seeing improvements. We talk about disparities, they're huge, they're real, but there's also a lot of good news here too. We are making progress. Some of you are aware of some data that we were able to publish with CDC a couple of months ago that shows that diabetes-related kidney failure has decreased 54% in American Indian Alaska Native people since 1996. Something's working. We are making progress. We haven't achieved equity or parity, but we are making progress. And for those of us who sometimes slog through the day-to-day, we sometimes go, oh, gosh, is it making any difference? Yes, it is. Diabetes prevalence among Native people has not increased since 2011. It was doing this. It's doing this. We'd like to think we're seeing maybe a little of that. We're not sure yet. We've got to see another year or two of data before we can say it. But that's exciting. And diabetes prevalence in our youth is still very low and not increasing. And obesity among our youth is also, while twice the US rate, it has not gone up at least back to 2006, maybe longer. That's the first year we have good data for. So there's a lot of exciting things happening. And bringing in this larger context of understanding how health has its roots in the earliest moments, days, years of life, actually even before conception, is an exciting new way of helping us all understand that science, as has been said before, is finally catching up with tradition, our Native tradition, and our understandings of the elders. So I did want to bring up those sorts of things. So everything I'm going to say is going to be kind of sound like an echo to the talk that Don just gave. But again, I think that's a good thing, that we are starting to see these patterns and the directions we need to keep going. So as the American Academy of Pediatrics said several years ago, many adult diseases, meaning heart disease, diabetes, depression, and all the related chronic diseases, starting to see cancer probably in this category too, many adult diseases should be viewed as developmental disorders. You can stop the sentence right there. I mean, that is just amazing to say that that's what these things are. They're developmental disorders, which again means that if we're waiting to adulthood to try and intervene, we have waited too long. And that these developmental disorders that begin early in life and persistent health disparities associated with poverty, discrimination, or maltreatment could be reduced by the alleviation of toxic stress in childhood. So again, it's giving us our direction, our marching orders, if you will. So just looking at stress and trauma, just a little bit more about those concepts. So stress just really is anything to which we must respond. We can call that, we label those things good or bad. For some people, pretty much everyone's going to say that, dealing with a natural disaster or a tornado or whatever you want is bad. Most people would agree with that. But what about having a baby? Is that a good stress or a bad stress? It's a stress. It's something to respond to, depending on your situation, depends on how you're going to label it. Then trauma is anything that overwhelms our ability to respond. And that is you aren't seeing what I'm seeing. Look at that. Okay. Trauma is anything that overwhelms our ability to respond, especially if we perceive that our life or our connection to things that support us physically or emotionally is threatened. Okay, and that sense of overwhelm is critical here. You may feel overwhelmed because it's just such a big thing that nobody, no matter how strong or smart they are, would be overwhelmed and feel like they could die or their family could be injured. But maybe it's because you're 2 years old and you don't have the intellectual capacity, let alone the physical, to address what you're dealing with. So traumatization is a lot of what we're talking about, of course, here. And trauma can cause lasting changes in the brain and the body that increase the risk for many problems. As Dr. Warren said, it's physical, mental health. It's also domestic violence, substance abuse, this whole panoply of problems that we're also familiar with. So, and any later experiences in our lives which remind the brain, the amygdala, part that has nothing to do with conscious brain control at all, of some prior trauma, can trigger the same physical and emotional responses that happened at the time of the original trauma. So if you are dealing with lots of trauma in childhood, and then later on in life you have other difficulties, even if they're not quite as severe, they can still trigger the same amount of cortisol and epinephrine that just come surging through, along with the emotion that you experienced at the time of that original trauma. So we are constantly swimming in this soup of stress hormones and emotion that really have their origins many times in earlier times in life. And that can make it very difficult for us to navigate successfully our current lives. Because when you're always seeing the world through the haze of cortisol and epinephrine and fear and anger and all those other emotions that come, are associated with traumas, especially in that early life when you may or may not be able to fully process and understand them, so they're not even fully thought out, if you will, emotions, right? They're just very primitive, primal things. That's how we spend a lot of our lives. And we all experience this. This is the universal human condition. But if you've had a lot of trauma and very little support, especially early in life, then this becomes the norm. And that becomes a problem in so many ways in your own life, and of course, when you become a parent. So trauma in children, when this trauma occurs during development of brain and body, as I just said, it can have lifelong impact. I do want to mention that we sometimes use these terms, and these two terms, toxic stress and complex trauma, have some similarity, so I've just put up a couple of standard definitions, common definitions, one from the Harvard Center for the Developing Child on toxic stress, which is when a child experiences strong, frequent, and or prolonged adversity, such as physical or emotional abuse, chronic neglect, caregiver substance abuse or mental illness, exposure to violence, and or the accumulated burdens of family economic hardship without adequate adult support. So it's the stressors without the support or the positive, the positive protective factors. And then complex trauma, similarly, is both children's exposure to multiple traumatic events, as well as their impact. And then adverse childhood experiences, which relates to these, but it is not exactly the same thing. We'll talk about it in a second. Of course, Dr. Warren talked about it. But they increase risk at any level in this graded dose-response relationship. So y'all are familiar with, these are the 10 that were in the original ACE study. As Dr. Warren pointed out, this is not a comprehensive list, and the ACE investigators themselves have acknowledged this many times. Back in the 1990s, this was amazing work. We get the opportunity to look back and say, well, why didn't you include exposure to community violence? Why didn't you include exposure to repetitive loss of family members and other things that impact our community so much? But when you consider the state of the science at the time, this was a remarkably comprehensive list. We just have to recognize that an ACE score based on this is not going to capture the full totality of the stressors and traumas that people have in childhood. But then the term, the ACE score, is not the number of experiences, but the number of categories that a person experienced before the age of 18. And we know that ACEs, of course, do have lasting effects because of all that surging of stress hormones over and over again. All that epinephrine, adrenaline, if you will, raising heart rate, blood pressure over and over and over, day after month after year. Cortisol, suppressing insulin secretion and increasing hepatic glucose output, and all those things that cortisol does that helps us deal with things in the short term, but over the long haul increases risk for diabetes and related issues. But it's not just those, it's also, of course, suicide, sexually transmitted illness, pregnancy in the teen years, so many outcomes to adverse childhood experiences, behaviors, and then, of course, life potential. So, and this is that graded response, so that having an ACE score of 5, 6, 7, 8 or more, yeah, that's really bad, but it doesn't start there, because an ACE score of 4 is a higher risk than an ACE score of 3, and an ACE score of 1 is higher, it creates more risk for these outcomes than an ACE score of 0. So that any exposure here, even if it doesn't meet that definition of complex trauma or toxic stress, still brings its own risk for later things. Now, it's important that we never label an individual as, okay, your ACE score is 5, so therefore that means you will. Because the ACE study did not include all types of trauma, it did not measure the protective factors. And so you can have a really bad ACE score because mom had a really bad boyfriend for a few months, but then but before it, everything was wonderful, and after it, as soon as mom found out, threw his butt out the door and got you all the help and support that you needed. You can have an ACE score of 5 that way, or because things were really bad your entire childhood without any adequate adult support. In fact, it may have been one of those parents who should have been helping you that was actually the perpetrator. So again, ACE is an amazing study and amazing information, but we need to look at both its strengths and its limitations in terms of what it does and doesn't measure, and also the comprehensiveness of the look at kids, and that it was a population study, not a study that looked at how to apply this to individuals. This is very similar to the slide Dr. Warren showed. I do want to mention, though, that we actually know a lot more about this little laser pointer is not very strong, but so adverse childhood experiences disrupting neurodevelopment, causing these impairments, but it's more than just the adoption of health risk behaviors. Yeah, that's one of the mechanisms by which exposure to ACEs increases later risk for chronic disease and social problems, but it's not the only one. Dr. Warren mentioned epigenetics. That's one of the ways that it's not genes inherited, but the genes we're expressing. And the genes we express depend on the needs we have on the situation we find ourselves in. Requires a different set of responses if you're living in a home with lots of love and support, good nutritious food, relatively low stress, versus the opposite situation. So gene expression is one of these. Another is actually how developmental programming happens in the womb as well as in the first few years of life. So that developmentally, if we have poor nutrition, which not just means calories, there's very little calorie malnutrition in this country, relatively speaking, but we have a lot of nutrient malnutrition. So if mom is not getting enough good nutrients in pregnancy, and even before pregnancy, because half of the nutrients that make up the baby's body, mom ate before she conceived, so that's the health of our young people, okay, and their nutrition status. But it's then what good nutrition or lack thereof did she have during pregnancy. That affects cell development, organ development, including in the kidneys, the pancreas, the heart, all of these critical organs that will later either be strong or have difficulties and help to contribute to chronic disease. So it's this perfect storm of issues that happen in communities of poverty and trauma. So while the ACE, again, study helps us a lot, there's a lot more than health risk behaviors that help explain all of those connections. So in our communities, this is the largest study I'm aware of on ACEs in our short of what Dr. Warren's about to publish, but this was 1,600 American Indian adults from 7 Southwest tribes, and this was done way back in the early 2000s. Of course, the ACE prevalence was very high in all the tribes studied. 2/3 of participants reported at least one parent as they grew up with alcohol problems. The most common forms of maltreatment in men and women, those were the percentages there, obviously quite high. And more than 1/3 had at least an ACE score of 4, so 4 or more. That's much higher than in the original ACE study. It was 6% of that 17,000 people in the original ACE study reported an ACE score of 4 or more. And in that original ACE study, of those who did have a score of 4 or more, they were 4 to 12 times more likely to be dealing with alcoholism, drug abuse, depression, and suicide attempt, 2 to 4 times more likely to smoke as an adult, rate their own health as poor, and have dealt with sexually transmitted infections, and they were 1.5 times more likely to be both physically inactive and severely obese, and the diabetes rates went along with that. The heart disease rates also were very high and went up in that graded dose response thing we saw on that last slide. So we have a fair amount of ACE, right? There's a news flash, right? None of us knew that. But sometimes it's hard for us to, and unless we think about it in an historical trauma context, to understand why, because, we say, well, except for racism, okay, how much of it is still coming from the outside? A lot of times we're now doing it to each other, so how does all that work? So this is just the way I look at historical trauma, and what's fascinating to me is all the different ways. It's like turning the crystal, and we all have kind of a slightly different view or way of describing this thing we're trying to get our hands around called historical trauma. But my particular take on it is that it's not about the past. It's a model which explains the present. How did we get to where we are? And so these are traumas that are often intentionally inflicted. And when we look at how, yes, it's bad if some natural disaster comes along, but if your own government or your own church or your own whatever is intentionally coming and doing these things to you, that has an extra layer of meaning to it that is very devastating. So these are often intentionally inflicted and occur at about the same time to a defined group of people. So these traumas have effects like individual traumas, a little bit like we were just talking about. But because these traumas are so pervasive, because they devastate parents, right, as well as children, they disrupt community and cultural infrastructures. So just thinking about that for a second. So when all of these difficult situations were happening, when there was genocide, when there was the boarding schools, so it was happening to groups of people at the same time. So it wasn't just the children who were affected, but the parents were devastated. The caregivers who should be there to help support their children through it were themselves devastated. And that is a crucial part, I think, of historical trauma, is that not only was it the risk factor, the trauma, but the loss of the protective factor of the parents because they were also devastated. So these things have huge effects on people's and communities' abilities to cope with and adapt to traumatic events and their aftermath, to our abilities to interpret the meaning and psychologically incorporate the trauma. How do you make sense of things after some huge devastating thing has happened to you and your family and your community? And then the vector of transmission of this trauma to subsequent generation, of course, is our traumatized parenting. Parents who inadvertently pass this along. They do not mean to. This is not a matter of character. It's not a matter of whether they're a good or bad person. This is just the way trauma works. So, of course, it's not unique to American Indian and Alaska Native people. We've just had a lot of it. We're not the only community by a long shot that has gotten to enjoy a lot of trauma. And as Dr. Warren mentioned, a lot of the research in this is actually in Jewish Holocaust survivors and their descendants. Interesting work not only on their descendants who were never even in Europe or in the camps. They were born here. Not only do they have altered cortisol and other stress hormone patterns, but they actually have alterations in their epigenetic expression of stress hormone markers. This is a very interesting recent area of study. So showing how trauma is literally passed along intergenerationally, not only through parenting skills, but also actually in genetic markers, gene expression. So, and of course, the traumas are ongoing. Not all of our traumas are in the past. Historical trauma, so to speak, is alive and well and going on today. Chronic poverty, food insecurity, and racism and discrimination certainly being very high among the list. So Dr. Warren had his model. This is the way, we all have different ways of looking at it. This is kind of my way of looking at these roots. So if poverty and this epigenetic and developmental programming stuff, which are the mechanisms by which we get under the skin with prenatal and early life nutrition and issues and stress and trauma, ACE things. Maybe these then really are the roots. Indeed, science is showing us that they are, of the tree, so to speak, that we all become individually and us as communities. And so if those are the roots, then perhaps this trunk, to use the metaphor, is the physiologic and behavioral ability we have to respond to life stressors. If our bodies are programmed to secrete lots and lots of stress hormones in response to many, many different types of stimuli in our environment as we go through our lives, and if the behaviors we learned are reactive, because that's what we saw our parents do, then this combines together to create a potent stew by which we have to try to figure out how to self-modulate. So we overeat because that helps reduce stress hormones and gives us a little squirt of serotonin in our brains. Alcohol use, drug abuse, emotional responses. So then after years and years of all of this, we have all these kinds of outcomes that can occur. And we have programs for all of those. Right? Every community pretty much has a program for those different things, whereas maybe we're operating on the wrong end of the tree. so to use this version of the metaphor. And of course, trees can only pass along what they have and what they've experienced. And epigenetically, we now know this is even more true, so that a tree can only pass along, its own experience. So seeds are planted for the next generation that will look a lot like what this one has gone through. So if those are the roots, where do we go? And we've been talking about it. So it's going to come down to these things over and over again: reducing stress and trauma, increasing protective factors, and improving nutrition. Food insecurity is a huge stressor. Children who are food insecure have more depression, they have more behavior problems, more school problems. So it's not only the developmental programming, as I talked about. Food insecurity is a huge stressor. It affects the way we eat for our entire lives. If you do not have enough consistent access to good food, it will affect the way whether you binge eat, how much you eat, your sense of desperation around food. It changes everything about eating itself for the rest of our lives, even if we end up with better ability and access to food later. So what are the answers? We know that sound maternal and fetal nutrition combined with positive social emotional support of children through their family and community environments will reduce the likelihood of negative epigenetic modifications and other mechanisms that increase the risk of later physical and mental health impairments. So here we go. We're seeing it over and over again. Simple but not easy. These are the things we have to do. And we have a study which is showing us that indeed these things make a difference, these three things. This was a study done by the University of North Carolina back starting in the mid-1970s. They took four cohorts of kids born in the mid-70s in the Raleigh-Durham, inner city areas, and the intervention was provided. I keep forgetting to. My slide here looks perfectly fine. Anyway, the intervention was provided from birth to age 5 years, and the intervention consisted of daycare, where they had great teacher-student ratios, and the teachers had special training in development of language, teaching emotional self-regulation, cognitive skills, gross and fine motor development, all that good stuff. They did parenting training. They brought the parents in and talked with them about how to better parent their kids by actually coaching them while they were doing it, while they were actually interacting with their children. So they did supervised play. So they were increasing protective factors by improving parental skills. They took care of food insecurity and food quality issues because they gave them, even if they went home to empty cupboards or only white bread and soda pop at home, whatever was available, at least here they got 2 meals and a snack of good quality food at the child care center, and they got primary pediatric care. So they did all those things. They reduced risk factors, they increased protective factors, and they improved nutrition. Flash forward, now these kids are in their mid-30s. They have lower prevalence of heart disease and diabetes risk factors, including better blood pressure, lower A1C or blood sugars. They are less obese, and they have higher HDL or protective cholesterol. So this is compared to the control group. So this is just showing us that we have literal, physical, heart disease and diabetes kinds of risk factor outcomes from doing the right things early. So we have proof that this actually works. So what do we have to do? This is going to look very similar to a slide of Dr. Warren's. We've got to prevent this transmission of trauma between generations. We have, so home visiting, there's a number of course, Family Spirit, having the RCT in our communities, but Nurse Family Partnership and others. Nutrition, we have to seriously address food insecurity and food poverty, food quality issues. It's not just did you go to bed hungry, it's what did you fill your tummy with. Obesity in this country, we sometimes say it's over-nutrition, very judgmentally. Most people who are obese in this country, it is over-caloried, under-nutrition. Because it's actually, our bodies know you have to eat more of that bad stuff that's available in order to get what little good stuff is in there. It's one of the many things that makes us overeat. We have to screen, detect, and intervene in children as early as possible. And we have to improve. I don't have it quite on here the way I'd like it, but we have to, in health, we don't talk about child care and daycare. We have to. Children spend more waking hours in childcare than they do at home. So even if we can't fix all the things that are not going right at home, if they get the good stuff at childcare, they get teachers, just like in that Abecedarian study, they get teachers who really know what they're doing, who are committed to bonding and attaching to these young children and helping them learn these skills. You can make up for a lot of what ain't going right at home by doing that. in the health field, we need to stop just talking about literal physical health and our programs that we put under that. We have to see things like childcare and nutrition as being critically important components. And there's now a lot of really interesting programs out there. I've listed a couple up there by nonprofits, Help Me Grow, Healthy Steps for Children. Some of them are based in clinics, some of them are based in the community, but there's a lot of things now that are helping us to find kids while those brains are still plastic and moldable, and we can make some changes that will be meaningful to fix, not having to do rewire, so we can really truly rewire in a good way, not just have to, to pretend that we are overlaying with stuff. If you wait later in life for children, those first few years are when, if things are going wrong and you make them go right, you really can make it much better. Increasing those protective factors, like I said, excellent child care and Head Start programs, finding any way to mentor these young children, make sure they know somebody cares about them. If it's in their family, that's fabulous, but if not, somewhere else. So boys and girls clubs, big brother, big sister, whatever it is, and of course having a healthy sense of who we are. And in our communities, that includes cultural self-identity. So anything that connects kids to their culture, whether it's through spirituality or language, but maybe it's art or games, and of course being mentored by elders, whatever it takes to help kids to connect to that. So just to conclude, I love this quotation from Eduardo Duran, a Native American psychologist and spiritual person, and he says, when it comes to problems anywhere, the medicine for that problem, the healing energy, as Dr. Warren said, the medicine is already within the pain and suffering. You just have to look deeply and quietly, then you realize it has been there the whole time. If where things went awry is through trauma, through loss of our parenting skills, through poverty, through poor nutrition, then that's where the medicine is. That's where we need to find our answers, find our resurgence. We are already seeing evidence that this is happening. It's our task now to take this more unified approach that now is bringing in the science and apply it in some very big and important ways. I'm honored to be here. I thank Alison and Johns Hopkins, Casey Family Foundation, and also NAFA for this session, and appreciate your all's attention. Thanks.
Thank you again, Dr. Bullock. It was great to hear from you. Next we have on the panel is Anita Finday, and she'll be speaking on There Is No Word for Foster Care, and we'll invite Anita to come on up, and as she's coming up, I'm going to introduce her. Anita Finday became the managing director of the Indian Child Welfare Program for the Casey Family Programs in 2011. She previously served as the chief judge for the White Earth Tribal Nation for 14 years. She holds a master's and MPA degree from the Harvard University's Kennedy School of Government and a JD from the University of Colorado School of Law. She has previously served as an associate judge for the Leech Lake Band of Ojibwa and the Grand Portage Band of Chippewa. She has also taught federal Indian law and policy at the Tribal College, University, and law school levels. So welcome, Ms. Finday.
Thank you. I am going to try and weave some of these things together, and I want to make one correction. I think in the agenda it says that I have an MPH, and though I wish that I did, I do not. And I have a master's in public administration. So my background is law. I'm an attorney. And so I have worked from a different angle with the same people that we have just heard the first two speakers talk about. So I worked as a tribal judge for my tribe, which is the White Earth Band of Ojibwe in northwest Minnesota. And I worked as a tribal judge there for 14 years and developed a court system, a judicial system that largely dealt with children in foster care. So I'm going to try and bring these two topics together a little bit and talk about the same children, the same families that we were talking about from a public health perspective, and I'm going to talk about them from both a cultural perspective and a child welfare perspective, just a little bit. But my goal is to leave you with some images in your mind that, so I was thinking about this day, and as I said earlier, this is our first joint endeavor with Johns Hopkins, and I think you can already see there's a lot of overlap between public health, and probably a lot of you don't know, I know we're heavy on the public health side in this group, but there's a lot of overlap between child welfare and public health. So we're talking about adverse childhood experiences, and probably one of the things that causes the most trauma to children. We know putting children in foster care is very traumatic. So that creates a lot of stress, toxic stress, and trauma for children. So it's something that we shouldn't do, but we do it a lot. And so I want to leave you with some cultural perspectives from where I've come from my reservation, and I think there's a lot of I think this is consistent. I don't purport to speak for all Indians or all of Indian country, but the things that I've learned from my reservation, I think resonate across Indian country. So I want to just say that, there's lots of pictures of Indian people. We see these old pictures, and so talking about families and how important families were, and what a good job Indian people did. A lot of the things that we know today that are our strengths, our protective factors, Indian people, we did all of these things. We knew really well how to take care of our children, and historically we were, we did a really good job, and we had extended families. You'll hear a lot of people talk about Indian country. You'll hear a lot of people talk about clans. We had clans, we had large extended families, and we were very, I think Dawn mentioned that first, talking about the concept of a nuclear family, a mother and a father and their children. That wasn't really the concept of families for Indian people. But in a lot of these pictures, so a lot of these pictures were taken of Indian people historically, and they're taken by white photographers. So they would take pictures of nuclear families, because that was their definition of family. So you see a lot of these pictures of people, but I think really, the point is that Indian families, they were strong, they were resilient, they had protective factors, but they had their own culture, their own language. We've talked about food. We've talked about, it was a completely different way of life. And so, a lot of these photographs are staged by white photographers, but I think that they really do convey a sense of the importance that Indian people placed on their children. You can see by, these are cradle boards that a lot of tribes used, and that they would wrap their children. And you can see by the design on the cradle boards, the time and the effort and the love that was invested in taking care of children, especially babies. Within a lot of tribes, you will hear elders say that, babies are closer to what we would call the Great Spirit, or our Creator. Babies are closer to God, and a lot of tribes believed in that specialness and in that sacredness of especially babies. So babies hold a special place in Indian culture and among Indian people. And this is another photo of a woman with her baby on a cradle board. So I show you these images that I want you to have a picture in your mind of what is resilience, what is strength, what is culture, and how did that play out with Indian people. The images, they may be staged in some respects, but I think they are true. And this is who we are as Indian people. This is where we come from, and these are the people. I think Al said it really well, talking about these are the people who wanted a better life for their children, for that baby, and they made great sacrifices to try and ensure that we would have that better life. So when I developed a court system at White Earth, they weren't doing what we would call child welfare cases in tribal court. The tribal court was not really functioning, and so we had to build a court system at White Earth that was culturally appropriate. And so I talked to a lot of the elders on the reservation and asked them, so we know that we have a lot of kids in foster care, and a lot of children are being removed from their parents. And so how did that used to work? How did you used to deal with, maybe parents who were sick, a lot of disease, parents who died, and people who were not able to take care of their children? And so I had the same story consistently from my reservation, and I think that this resonates in Indian country broadly, is that traditionally it was always our way to take in children. We took in children who were relatives, nieces, nephews, children whose parents, for whatever reason, could not take care of them. And I also heard stories about Indian people taking in non-Indian children, that settlers would come to the area, people were going west, and people would get killed. I think life expectancy was low. Then we're talking 18 and early 1900s. And so what the elders consistently told me was that we always took in children. Whether they were our blood relatives, whether they were members of our same clan, or if they were children, that we took in non-Indian children and we raised them as our own. So this is an environment that was, and some people joke and talk about Indian people and that we were too welcoming. We should have, the stories of us feeding people who ended up on our shores, and maybe we were too nice, and those people, we know the consequences, right? But for Ojibwe people, and I think for many tribes, this is who we are. We are a giving, we are a generous, we are a welcoming people. That's our culture. This is what we do. This is the tradition of where we come from, is that we take care of children, and we always have. And I think I think the title of this piece is about the fact that there is no Ojibwe, and I would not say that I am a master at the language of Ojibwe or at any other language, but we were doing some brainstorming with Melissa Clyde, who's one of the team of Indian Child Welfare at Casey, and we were talking about language and the meaning that language carries. And so I went out and, asked people, so, did you ever have like foster care, or is there some word for taking children away from their parents? And there's not. And I bet that there's not in any of our traditional languages that there aren't words for these kinds of things, because we didn't need some outside agency to come in and take our children. We took care of our own children. And so some of the elders did talk about parents who for whatever reason, were unable or unwilling to take care of their children, and that people would take them in, and people would take the children in, and they would take care of them. But when the time came for those parents, when they decided, or when everyone decided that they were able and willing to take care of their children, they got them back. And so there is no word for adoption. There is no word for termination of parental rights. And so those of you who don't work in the child welfare world may not know this terminology, but this is what we who work in child welfare, this is what we do. We remove children from their parents' care, and if we give them a certain amount of time and to get their act together and to fix everything that we've said they needed to fix, and if they don't, we terminate their parental rights and we take their children away from them forever. And so I used to work a lot in the state court system, and I became very disenchanted with the state court system, and then set off to develop a tribal court system. In the state court system, and I would say this is true in every state, if your parental rights are terminated to your children, it's as if you never existed. Your name never comes up in future court hearings. It's as if you just disappeared, magically disappeared. But yet if you talk to those children about who is your mother, the fact that parental rights were terminated doesn't mean anything to the children. That is always their mother, always their father, and that is always where they want to return. They want to return to their mother. Even though things may have been pretty bad, they always want to go home. So there is no Ojibwe word for adoption, and I talked to Ojibwe elders about this, and they said, well, there are words for taking people's children in. We took people's children in all the time, but we gave them back when the parents were able to take them. So this word for adoption does not exist, although there is, in my tribe, and I don't know if other tribes did this, we would adopt non-Indians into the tribe. People who married into the tribe, who married a tribal member, they would become a member of the tribe. And I don't know if other tribes did that, but we were very open and generous, and we were welcoming to others into our communities. So I think you can see these pretty good. So I was thinking of Anne's presentation that I would have liked to have inserted these photos where she was talking about, so I hope you can see those. So these are before and after photographs. These are this is the same group of children. And so these are kind of iconic photographs now. And so if you know anything about Indian history, you've probably seen some of these. And so the picture on the top, this is a group of Apache children. And so this is the boarding school era. And so these are Apache children who were removed from their family. And at the top, the photo is of them when they were first removed from their family. And I don't know, I don't think anyone, I haven't read anything about this photograph, about whether, I know that these are all Apache children. I don't know if they're related, but they are all from the same tribe. So the top picture is when they were first removed from the reservation. And the photo at the bottom is after they had been at, they are at Carlisle boarding school in Pennsylvania. So I think of this photo as the epitome of toxic stress, adverse childhood experiences. So these are children who were taken from southern Arizona, and they were brought to Pennsylvania. And so these removals of children, these were done by the federal government. This is an official federal policy for Indian people. And it went on for 100 years. And so children were removed. And you can see that there is a systematic approach to replace everything that the children had known. So first off, they're removed from their parents. And this group of children may have been more fortunate than others in that there's a group of them from the same tribe. So you can see in the second picture that one of the girls has taken on probably a mothering role for some of the younger children. But you can see that everything has been replaced. Everything that was what they knew as who they were, their complete identity, their clothing, their hair is cut. So they've been removed from their parents, and we know that they were no longer allowed to speak their tribal languages. Most of them did not speak English, so they couldn't say anything. So this is kind of an iconic photograph of what we've talked a couple of times about boarding school, but I think it's really helpful to have an image of exactly what that meant. Dr. Warren talked about his grandmother, I think it was his mother, being in boarding school, and my grandmother was in a boarding school, and my grandmother did not talk about it. So we know that children were severely punished, and there is a saying the founder of the boarding schools had was to kill the Indian and save the child, and that was the theme that the boarding schools tried to implement. So here is another photo, and so again, this is another iconic photo. This is the Carlisle boarding school in Pennsylvania. So just to give you a sense that we are talking about a lot of kids. This was not, just a little group of 20 kids here and there. This is hundreds of children and who are forcibly removed from their families And lots of times families were told, so Indian people were rounded up, forcibly placed on reservations. Many fought really hard to not be placed on reservations. And some of the families were told that we talked about their food. Their guns were taken away when they went on the reservation, so they could not hunt. So they're completely dependent on the rations that you saw. That's why they're making fry bread. There's no other option. And so some of them were told, if you don't allow us to take your children to boarding schools, you'll no longer receive that food. And so they had very little choice but to cooperate with the people who had the boarding schools system. And so the next slide I'm going to show you. I'm going to make this huge leap to today, but I want you to have this image in your mind and think about. So this is now 2 generations before, but Dr. Warren and I both have family members who, my family went to this boarding school, most of them. And the thing that I would say about my grandmother was, she didn't talk about this. She would never say that she went to a boarding school, but she also, she didn't hold children in her lap. She did not hold children because she grew up in a system where no one held her. And so that is transmitted, that if you probably know, maybe some of you know about infant mental health, and that the necessity, the need to bond. I think someone mentioned that. Well, if this is where you grow up, you don't bond with any adults, and you don't have those connections that we all know today that children need. So this next slide, and this is my belief that the boarding school era continues to play out today. So this is a slide that's put together by the Minnesota Department of Human Services. And I don't want to pick on Minnesota, but it happens to be where I live. And they happen to do a pretty good job of keeping data. So this map shows the out-of-home placement rates for Indian children in every county in the state of Minnesota. So the purple color is overrepresentation of Indian children in the county child welfare agencies. So there's a lot of purple, and but 2 things that I want you to really notice. So if you're not child welfare people, I'll just tell you that nationally, the rate for kids being in foster care is about 5 children per 1,000, or 5.1. That's the national rate of children in foster care. And I hope that you can see, so there are 2 reservations in Minnesota that report AFCARS data. AFCARS data that's the federally required child welfare data. Most tribes don't report it, but there are 2 reservations in Minnesota that do. And one of them is my reservation, White Earth, and they are in blue. So if you see that blue kind of squarish, that's the White Earth Indian Reservation, and our rate is 177.7. So that means that per 1,000 children, 177.7 are in foster care. So it's about 18% of our children are in foster care. And so if you look at the Leech Lake Reservation, which is just to the right of the blue square, Leech Lake also reports data, and their number is 90, I think that says 92.7. So that means that they have, out of 1,000, every 1,000 children, 92.7 children are in foster care. So disproportionality, I've had people ask me if that can be right. The numbers seem so huge that it doesn't, some people think it doesn't even seem possible, but it is accurate, and those are the numbers. So I think that's the image I want the last image I want to leave in your mind, but I want you to merge this. This is child welfare data, and normally child welfare people and public health people don't talk to each other. We have our own silos that we operate in, and so I'm hoping that this convening and the future work that we do together is the beginning of a merger of talking about child welfare and public health. The children are the same. They are the same children, and probably at some point we need to talk about juvenile justice, right? These are the kids that also end up in prison. This is the pipeline to prison. And so we know from the data that these children have a very high rate of all the bad things that you don't want to have: suicide, prison, unemployment, low and high rates from diabetes, all of the public health data. So I'll leave you there, and I think we have some time for questions. Thank you.
Okay, thank you again, Ms. Fine-Day. I'd like to invite the three speakers that just spoke to come go ahead and have a seat up here. And we have about 15 minutes for questions. So if you have any questions, just go ahead, and I think there's microphones around. Just stand up and go ahead and ask our questions. Thank you. Do we have any questions?
I have a question for Anita. So very stark picture, very hard to take in. Dr. Warren talked about policy warriors. We need to be policy warriors. So what would you want your policy warrior to do with this information?
Well, I think that first, in the beginning, we just need to be aware of where things are, right? And I was very encouraged to hear that, the rates of obesity and diabetes at least have flattened. So that, to me, is a really good indicator. I think that all of these things go hand in hand, right? So that is very promising. But I think in Anne's slide, I think she had some of the programs that we know work, home visiting, and she also said, I loved her presentation. I thought we should let's just merge our presentations, but talking about prenatal care, because healthy children start, before they're born. So education, the home visiting programs, the things that we know that work, strengthening those programs and working. We should not, we're just adding trauma by removing these children and placing them in foster care. It doesn't work. And so we need to be focusing on prevention.
Okay. Question over there, if we can get the microphone to. Thank you.
Good morning. My question is to Anne. I was just curious because we run a program, CHN program, and we do home visiting, but I'm curious to know how your family spirit and nurse practitioner partnership works. What's that process?
Right, so there's a number of evidence-based home visiting interventions. And, you know, like in any country, we need to make sure that what we're doing, you know, has evidence, whether it's in the, you know, the medical, traditional scientific model, or at least what, or sometimes even better, what we know works from our own communities. But in terms of the scientific model for that, there are a number of evidence-based home visiting interventions that include family spirit, which we'll be hearing about a little bit later today, et cetera. So what I was referring to is that for our special diabetes program for Indians grantees, they are, we've made it very clear to them that because of the evidence that they help reduce obesity-associated risk factors, that they can use STPI dollars if they wish. You know, they get to choose the types of projects they wish to work on, but if they wish to, they could do that. So that's just one aspect of it, but there's a number of sources of funding that tribes are using now to implement home visiting. The McVie funding, part of the Affordable Care Act. We certainly hope that gets, continues to be funded, going forward, as well as just tribes using their own funds to implement projects, whether it's Family Spirit or Nurse Family Partnership or many of the other evidence-based home visiting interventions. They're happening around Indian country, and it's very exciting to see, what those programs are doing and how they are helping, some of our most vulnerable, young, usually women. We hope the fathers are involved too, but the women at least. So I was referring to it in terms of our STPI program, but there are many other ways that our tribes are implementing these really great programs.
Thank you. Any other questions? Okay.
Good morning. My name is Alan Shedlin, and I'm with the Dadvocacy, good word for you all, Dadvocacy Consulting Group, and I'm wondering, are you aware of any of the home visiting programs that really make a special effort to include the dads?
I think that there are a number of them that do make an effort to do that. In terms of how it's incorporated into the intervention itself, I think it varies depending on the home visiting intervention. My understanding is that they all have an interest in including the fathers as much as they are willing and able to be included. But I would hate to speak for each individually, but right. I'm sure it's an area that all of them would like to have more success in.
Choctaws in Oklahoma had a home visiting program for fathers of Choctaw children. So I think that's right. Most tribes are taking the initiative on as they can.
As well as other family members too, that must be stressed, especially in tribal communities. So yes, moms, yes, dads, but grandma, grandpa, auntie, whoever it is, who's directly or peripherally involved in that child's care. I think a lot of them are trying to reach out and be more inclusive and not see things just in the nuclear family model.
Thank you. We have a question in the back.
Hi, my name is Shelley Weekelt, and I teach at the University of Maryland, Baltimore County. I also do some work with Native American Lifelines here in Baltimore City with urban American Indians. And I'm listening to your presentations, and I appreciate your words and discussion about historical trauma and its impact on people's lives, and the need to do some prevention work, and the need to honor people's families and bring people together. And all the programs that you talked about sound very wonderful. But I'm sitting here thinking, over the years that I've been in practice, much of what you're talking about, we've been talking about for a long time. But things don't change. They change a little bit, but they don't change enough to make the sweeping improvements that we need. I mean, you mentioned we have improved. Yes, we have improved. We can see progress, and that's terrific. But it seems like to really heal, we need some kinds of sweeping changes. And it's not lost on me that we have a president who has a portrait of Andrew Jackson in his office. So that brings to mind to me how I would like to hear what you think about how we can approach this and continue to make progress, and even make sweeping progress in a time where we're talking about cutting food stamps and cutting Meals on Wheels and cutting children's programs and cutting Head Start. The kinds of programs that you're talking about are going to take money and funding and time, and they're very much needed. But in the current political climate, and even in the historic political climates, even in times when we've been generous with our funds on a national level. It's been challenging, and I'm interested in your thoughts about that.
I'll try not to give a political answer. I'll just say that I have been concerned. I don't think I've heard this administration really say the word children yet. So I think that is a concern. So I'm not a researcher, but I can convey what I heard a lot of researchers talk about. I think maybe a couple of months ago, the Federal Reserve Bank, who has a Center for Indian Country Development, had their research conference about children's issues. They do a lot of research on children's issues, and it's the Federal Reserve Bank. The Center for Indian Country Development is located at the Minneapolis Federal Reserve Bank. But so at their research conference, and it was the first time I had attended, and the gist of what I got from a lot of the speakers is, and I think this is your question about sweeping change, is that there is no magic bullet, and that if it's going to be small, incremental changes that will have a cumulative impact over many years. And that is what we have to be seeking, are the small incremental changes that will have a big cumulative impact over years. So I guess that's kind of the bad news, but it's also the good news, right? So flattening out, we don't see spikes in the things that we're looking at in all of these factors. And then hopefully that line's going to start to drift down. But so that's what researchers, that's the message that I got from the researchers.
Absolutely want to give you 1 second, because I definitely want to be able to answer this too. We have been talking about these things for a long time, but we have not actually been focusing our efforts on these things. And I think that's the crucial difference. We have seen incremental change and some very important, and more than incremental, some remarkable changes actually happening. The improvements in the food stamps program and and the commodities program and things, in the WIC program, these have all been very important and they have helped. But when it comes to us in Indian country, coming to a meeting of the minds on what the really important thing is. I remember when I was working for the Eastern Band of Cherokee, and all of us getting together and saying, where do we break this cycle? How do we do this? And this was only probably 15 years ago or so that we were asking ourselves that question. The science is now very clear, and you're starting to hear a consensus that is really developing, that it is in this intergenerational time. So it's right before young people become parents, conception, pregnancy, first 2 to 3 years of life. These are the critical times when change can happen. So while we've been talking about it, we haven't actually had that let's all move in the same direction, not uniformly, because there's so many wonderful, creative, different cultural variations on things, but to move forward with these things. I think that's actually the charge, in a sense, to all of us that should come out of things like today's meeting. So that's what I would say, is that yes, we've been talking about it, but now we have a much clearer vision of that, and I think you're seeing that coming out in all of the presentations we've just seen so far, and that's an important aspect of it.
You have a very good question there. I think the key here is that we Native people got to believe in our own people first. Because, like I said, we have this program. We have not received 1 penny from the federal government, no money from any state, no money from any private foundation. We have one donor. She's from Ohio. For the first 5 years, she donated $5 to us. The last few years, she's donated $10 to us. I have seen, you get the men involved, the fathers, and you get mothers involved. They believe in their children, they believe in each other. But how do you get them involved? You really truly have to love them and love what you bring to these people. But I think that many times we are so dependent on waiting for the government to do something for us. And many times people don't make decisions in our best interests. But fathers and mothers make decisions in their best interest for their families. But we have to believe in them. We have to really believe in them and trust in them. And I have seen Native people across this country do this, you know. And so if we wait for a government program, look what has happened for the past 200, 500 years. We'll be waiting and waiting and waiting. We gotta find a way to involve the fathers. And I keep stressing that most programs focus on women and children and teens, but leave the father out of the whole equation of the family. We, as youth professionals, we need to bring them back in. And I think that when you get the fathers back involved with them, they do phenomenal things, whether it's in the criminal justice, whether it's in the health and human services area. And so I'm a big advocate of fathers. And so, like I said, we have 207 programs throughout North America. And so we'll keep doing that, whether we have any help from anybody else. We have a mission to get fathers to really strengthen families throughout this country, Native families in particular. In fact, what we're doing now is that we're now meeting with the United Nations. We've been invited to go to New Zealand, Australia, and Samoa. We've been invited to possibly go into South Africa also, and with no money from the federal government.
Thank you again, everybody. We appreciate the questions. We're unfortunately out of time. Oh, quick question. Go ahead.
I just have one quick question, maybe more of a suggestion. Good morning. I'm Dr. Mayer from Fort Berthold Indian Reservation in Newtown, North Dakota. I was a family practice physician for 22 years, all my service on the reservation in the Great Plains. And then, I don't know, I think I have to have my head examined. I threw my hat in for running for council, and I won. So I'm the first woman in my segment in the history of my tribe, the Mandan, Hidatsa, and Arikara. You all know us from oil. We're a very wealthy, energy-rich tribe. And I'm the first American Indian woman physician in the Great Plains to sit on a council. So I bring a new hat to the audience, and I like the idea that we're breaking silos down and sharing information for the first time that I've seen. But I'm coming from, this information needs to be shared with your political leaders. I don't believe that the new President Trump's administration is gonna have, you know, an open door policy with American Indian people's needs. We're just not a large enough population for him to take notice. And secondly, we're not a very large population of concern. But as our speakers all have mentioned, you know, when I opened up my first paycheck and it wasn't even half of what a doctor makes, I knew I had to have my head examined. But the point is, we don't need a lot of money to take care of our children. We need love. But we still have to have our social services, our healthcare hats on, our legal hats on in CPS, our political hats. And that's what I'm asking, is that we look at all the entities coming together to present at NCAI or some major organization to focus on fatherhood in Indian country and children in Indian country and motherhood. And that we tear our silos down and do grassroots, because I know as a newly elected politician for only 6 months, I ran on healthcare in Indian country. And I think that politically, I sit on a council with all men. I'm the only woman. And women have different eyes than men about things. Men think commerce and economy and making money is more important, whereas us women think about health, our families, and our children's needs first. And it's two different perspectives, but most leaders in Indian country politically are males. And I know the Navajo Nation only has one woman on their council, and there's 18 of them. So I would hope that we could join forces in all of our entities at NCAI or some major American Indian conference and bring together I'm just planning a Johnny Appleseed with Casey family and John Hopkins to hope that we can bring these forward from our respected presenters to present in a unified force. Thank you very much.
Thank you again, Dr. Mayor.